So anyway, like I was saying, this is how you actually do your job as an EMT. There's two aspects when it comes down to it. For the hands-on portion of actually doing your job, there's a couple of things. First of all, we got to provide treatment, right? If somebody's got a heart attack, we need to be able to provide the treatment that we are able to provide to help stabilize that patient and get them to a hospital. We can't cure a heart attack. We can't fix trauma. There's all this stuff that we can't do, but there's a bunch that we can. You know, our job in the field is to stabilize a patient and get them to a hospital. That's kind of what we do. We stop the downward spiral, and then we get them to the hospital where they can actually get definitive care. And even at the paramedic level, a lot of the stuff that we do is to stabilize, not necessarily to fix. So, but to be able to do that, you have to be able to figure out what it is you're looking at. And there's a couple of things that come into this, right? We go into some unsafe situations. That's just the nature of our job. So step one is always going to be along the lines of making sure that we're safe, making sure the scene is safe. It doesn't have to be safe like, you're walking into a kid's park kind of safe. It can be, there can be some threats to it. That's just the nature of it. But you want to make sure that whatever it is that happened to your patient doesn't happen to you. So that's always step one. We do our job basically as from an assessment standpoint, and it begins with your body substance isolation, which is your BSI, is what we always call it for short, and your scene safety. Once you know that the scene is safe enough for you to enter, and you've given it a good look around to see what you're dealing with, then we start dealing with the patient itself, and we'll begin with the life threats. Then we typically go into something, so we're going to work on it from a standpoint of fixing what's going to kill them quick. Then we go back and we fix what's going to kill them in a little while. Then we go back and we fix what might last, might get out of hand if we leave it alone. And hopefully by then we're at the hospital. But we have an assessment-based approach, and that's what we're going to talk about tonight. This is the bread and butter of your boot camp. Everything we do in boot camp is basically the hands-on version of this chapter. So we are going to hit this every single night in module 3, in module 4, and technically a little bit in module 5. So every time we bring in a new illness or a new injury pattern or something like that, one of the things that we're going to do is we're going to present it in the form of an assessment as to where, like, how, if you deal with this in the field, here's how it would play out through your assessment. And so that just makes it a little bit easier, a little bit. So when you walk into a scene and it looks like something straight out of a Stephen King horror movie, and you're like, holy shit, what am I looking at? This is how how we still get the job done, even though it looks like the world just blew up around us. All right. So like I said, we're going to get started, and I'm going to show you a copy of one of your assessments, and all of your assessments that you need are going to be in the files portion of Canvas. You can also download these directly from the NREMT website, because when you go to do your skills, this is what you're being graded against. They want to make sure that you can get through your assessment, not just from beginning to end, but also to make sure that you know where certain things are. So like, for example, you may get a registry question that says, you arrive on the scene, an EMT is already taking care of a patient, and you're going to take over patient care. The EMT tells you that this is the last thing he did. What's the next step? And this is where those registry questions get kind of hard, because you're looking at your 4 options, and all 4 options are on your assessment. They're all right answers as far as, yes, I would do this, yes, I would do this, but which one is next? And that's the question. It matters where the EMT left off, to determine what the next step is. If he's still working in his primary, then any of the question or any of the possible answers that are way off in the secondary or in the reassessment aren't going to be the right answer, because you're not to that part of your assessment yet. And so that's what we're going to talk about tonight. I'm going to show you guys how the page is laid out, and you're going to hear me get on my soapbox about how horrible this page is laid out, because it screws everybody up. So I'm going to try to paint it in a different way. And if I do that early on, I think it'll make the assessment make a lot more sense when we actually start doing it. And you'll see what I'm talking about, because when we look at this, you're looking at this like the higher up on the assessment, the more critical it is, right? Well, why is it then that you get a third of the way down the page and suddenly it's all about asking what their allergies are? That's just the way that they put it on the paper. It doesn't necessarily mean you have to follow in that order. So I'm gonna try to show you guys a way that's just more efficient for you, more efficient for the patient. You still get everything done, but it'll help you see how the calls actually flow. And then so there's less of a gap between when people say, forget what you learned in school, here's how the real world operates. To show it to you this way, they're going to be much closer to the same thing. So anyway, without further ado, let's get through this. A lot of these slides are going to be skipped tonight because they really are more hands-on based, and then we're going to skip those in lecture because you're going to get all that in the boot camp. So again, your patient assessment cannot be overemphasized. This is the structure that we operate with, and it's not so much that it's supposed to make it standardized where you don't think for yourself or use critical thinking. It's just this is how we know we're hitting all of our bases, checking off all the boxes, and we're not letting something distracting pull us away from what matters. For example, you walk up to somebody and they've got a mangled up leg, looks like they got bit by a shark. We don't want to go, holy crap, your leg's messed up, and focus on that, and then not pay attention to the fact that they might have broke their neck or they're not breathing, something of that sort. Your assessment is divided into 5 main parts. We have your scene size up. This is going to be where you basically do your safety check to make sure that you're not walking into a trap, essentially. You're also going to get an idea of what you're dealing with. How many patients do I have? Do I need extra help? And that extra help could be in the form of paramedics. It could be in the form of just more ambulances in general, the fire department, the power company, a hazmat team, the police, any of that stuff. Your history taking, your secondary assessment, and your reassessment. Now, this is, I'm going to try not to get on my soapbox. I'm going to restructure this a little bit for you guys. Imagine that you have your assessment broken into categories. You have your scene size up, your primary assessment, your secondary assessment, and your reassessment. And we're just going to say that that's it. Your history taking, I clump that with the secondary, and I'll explain how it works when we get to it. I just think that the way they do this, they've tried to make it so detailed they actually screw people up. But the order in which the steps are performed really just kind of depends on the patient's condition, which is kind of my point. You may not want to create the history taking. You might show up and somebody is all mangled up from a motorcycle accident, and you're like, holy crap, we got to get in the truck and go. Well, that means you have to move your patient. How are you going to move your patient if you don't know where all of their injuries are? So that part of the assessment should probably take precedence over what their allergies might be. That's the kind of thing I'm talking about. And the way that these things are listed, which I'll show you in a little bit, they're all listed in just one column. It gets a little difficult to figure out how to really get into the meat and potatoes of the assessment, because it's not I don't want you to just learn step 1 to step done. For your reassessment, that's just basically making sure that their vitals are still in check. If you had to do any life-saving interventions, that those interventions are still working. And then how often do we reassess, which also depends on the condition of the patient. Rarely does one sign or symptom show you the patient's status or underlying problem. And again, so you show up to somebody and they say, my chest hurts. Well, there's a lot of things that can make your chest hurt. Same thing with a stomach ache. You show up and they're like, well, my stomach hurts. Well, it could be hurting anywhere in there. And most people, when they say their stomach hurts, they're not referring to their actual stomach. The stomach sits really high. That's just what we call it. But that could be any one of those organs. Could be your musculature itself, could be a bone, could be blood vessels, any of that kind of thing. So your assessment helps you try to narrow down, figure out what you're dealing with, and then you can provide the right treatment, because we don't want to give a cardiac drug if the problem is actually the appendix or something of that sort. Excuse me. My throat's been draining all day. The treatment that an EMT provides the patient is based on the symptoms, not an exact diagnosis. And that's pretty huge. We don't actually diagnose our patients. That's the doctor's job. We operate on what we call an index of suspicion. So if it walks like a duck and quacks like a duck, it's probably a duck, and I'm going to treat it as such. However, I could be wrong. So, if I've got somebody tells me that they were in a car wreck and their bone looks pretty mangled, but I don't actually see it sticking out the skin or making a gross deformity, I could assume that they've got a fracture, and I'll stabilize the bone as such, but I don't know. not without an X-ray machine, not to say definitively, because I'm also going off of what the patient tells me. And if their expression of pain is a little different than what I'm expecting it to be for a broken bone, then it can kind of lead me down, I might not be right, but you just do the best thing you can. And either way, you're treating symptoms, um, stabilizing it, making sure they don't get any worse, get them to the hospital, let them go to X-ray, get it seen for sure, get it diagnosed, and then they'll get a cast, like a real cast. We don't, we'll just put them in a splint. But the cool thing about this that I really like about your assessments is any existing EMRs, y'all already know this. There's no difference. If you guys go on to advanced EMT or paramedic, when you get to the scene side or to the patient assessment chapter, congratulations, you already know it. It's the same for all levels. The only thing that really changes is what can we do within it. So, your paramedic is still going to do the scene size up, still going to do the primary assessment, secondary assessment, and everything. And there's no extra stuff. It's not like we're hiding anything from you. It's depending on what they find, they can do extra stuff. They can give pain meds. They can set an IV. You can't do that. But there's still plenty of stuff that falls under the BLS standard that you can do. And you're going to look at the patient in the same standardized way, which is, like I said, which is great because you and your paramedic are looking at the same thing. If you go on to paramedic school, you're already geared and trained for this. That's why EMT is a prerequisite for paramedic. It's just easier that way. If you didn't already know this, paramedic would almost be impossible because they're still throwing so much other stuff at you clinically. All your drugs, medicine in general, the different interventions you can do. If you were still trying to learn this at the same time, it would be almost impossible unless you took an extra semester, which is essentially what EMT is. So like I said, we're going to break this into sections. The first section is your scene size up. You want to figure out what it is you're dealing with. You don't want to ever go into a situation blind because you don't want to get hurt as well. So scene size up refers to your evaluation of the conditions in which you will be operating. Situational awareness is huge because just because it's safe when you arrive doesn't necessarily mean that it's going to stay safe the whole time you're there. Like for example, I'm gonna call on y'all a lot tonight, just kind of open things up and get people talking so that I'm not ranting and raving for however long it takes me to get through this chapter. Um, Somebody give me an example of an unsafe situation. What is something you would not want to walk into? Probably would have helped if I pulled up the checkbox. Okay. All right. Yeah. A domestic situation. If two people are in a fight, you don't want to walk in the living room while they're still fighting, right? Um, now walking in after the fight, absolutely. You got to provide care. But if you're going to show up while they're still fighting, probably going to want some law enforcement with you. We don't typically carry weapons, and for good reason. That's not our role. Um, you don't want to be in a situation where you're forced to defend yourself because you shouldn't have been in the situation in the first place. It's one thing if you're in a safe situation and your patient becomes combative. Obviously, don't just let them hit you. I'm not saying don't defend yourself, but you shouldn't willingly walk into a situation where you know you're probably going to have to defend yourself. That's a point where we just wouldn't go in. All right. But it's not always black and white. Like let's take for example, here's a car wreck close to heavy traffic. That's a good one, especially with rubberneckers, people texting and driving who don't have a clue. Even not just that, you know, flashing lights can set off seizures, right? So if somebody is driving down the road, sees the flashing lights, and has a seizure, they could become a problem. Um, Crowds, yeah, wild parties, especially if anything is happening that's illegal. They see you in a uniform, they may mistake you for police and not want you to be there. Because all of our uniforms kind of look the same, unless you're wearing like a polo shirt or something of that sort. But there's some of them that aren't always black and white. Let's say that you have a call where you show up to the house and the person is sitting in the chair looking at you, and or even better yet, I'll put it like this. You show up for a drunk person passed out. All right. You get there, you're in your scene size up, and you see your patient. He's passed out, and there's a weapon sitting next to him. Can you or can you not approach that scene? Would that be a problem? He's currently unconscious. Okay, yeah, safety first, right? So we need to address that one way or the other. Let me ask you this, and I'm not getting into the politics of weapons and Second Amendment or anything like that, but if the weapon's just sitting there, is it a threat? There you go. Travis, you got it. They could be. They could be acting. Going off the assumption that they're not, that they are passed out and the weapon's just sitting there. You can approach, but move the weapon. Get the weapon out of the reach of the patient. Um, yeah, there you go. So you can, my point being is that you can make a scene safe. All right. If you're able to mitigate it, if you're able to make it safe, great. The question becomes when you don't want to move forward is when a scene is unsafe and it's beyond your control to do anything about it. So the domestic dispute, that's an example. Rabid dogs would be an example. If it's a shooting and they haven't apprehended the shooter yet, the shooter's still like an active shooter scene, we don't go in while the threat's still there because we can't control that. But if it's something you can mitigate, say the guy's even awake. There's been calls where I've walked in and the guy was cleaning his weapon or whatever and started having a medical emergency, and we sit down, or he sits down, calls 911. He called us to be there, and he's got his weapon sitting on the stand right next to him. Doesn't mean we can't move forward just because there's a weapon there. It just means, we'll walk in like, hey, sir, before we even approach, we're like, we're here. We're the EMTs. You called us. We're here to help you out. Um, are you okay if we move your weapon to the other side of the room? Something like that. And normally, if they're not gonna, if they have no ill intentions, usually they're not gonna fight that because you're not taking it away. You're just taking it out of reach. And you can even tell them like, we're gonna leave it in sight so you know where it's at. We just want to get it out of your reach. Most competent people, especially people who called because they actually need you for something, are going to have no problem with that. So that's an example where your scene can be made safe and you move forward. But again, this is your first couple of steps, right? And your scene size up is made of, you have 6 steps. If they say no, you may have to just back away. I'm not saying be like, all right, cool, well, I'm not going to help you, but you can just tell them like, I'm sorry, I'm not, I want to help you, but I can't, I don't feel comfortable doing this with the weapon right there. Can I put it somewhere else? Can we meet a compromise? You can ask him because again, if he's not showing a threat, it doesn't mean you have to run away. It just means you want to make the scene as safe as you can. And you never know. Sometimes because you don't know what they may have behaviorally. They may be fine one minute and then be bipolar and suddenly flip out on you. So you don't want to just say, okay, no, don't worry about it. But if he doesn't want you to move it away, then maybe you can have him show you from a distance that it's empty, no bullets in the chamber, that kind of thing. So it's a judgment call. You can do whatever you want if you need to. Just you want to keep your safety in mind. And yes, you can call the police. Um, that's always a good idea. I mean, what are they going to do? Tell you no? So call the police, get them out there. That helps. All right. Anyway, back on the scene size up, there are 6 items in the scene size up that I want you guys to remember because the size up is what I've noticed when we're doing assessments. Usually people will mess up in the size up because they immediately want to start thinking about taking care of their patient and they forget about the build up to it. But they know they got to get these. And so they're ready to jump into their primary assessment and they start naming off, all right, BSI, scene safety, number of patients, blah, blah, blah. Oh, crap, I forgot one. And you're being graded. So now I'm worried about remembering what it was I forgot. Plus, I'm trying to move forward with my assessment. So I'm thinking of what I've already done because I know I missed something. And I'm trying to remember what I'm supposed to do. And I start missing more because I'm stuck on that scene size up, trying to figure out what it was I missed. So especially starting off, I want you guys to be masters of the scene size up. There's only 6 lines. In the first 2, we always say them together. You ever hear anybody make fun of the whole BSI scene safety thing? That's how we start, but that's the first 2. It only leaves you with 4 more. In the total 6, BSI is one, scene safety is the other one. So you protect yourself from body substances, right? Put your gloves on. Make sure your scene is safe. Everything else has to do with kind of painting the picture of what you're dealing with. How many patients do I have? If you've got one patient, fantastic. That's all you need. What if you have two patients, five patients? Can you take care of multiple patients by yourself if they're all critical? No, not really. Not good, at least. I mean, you might be able to kind of bounce back and forth, but if they're critical, they're going to grab your attention and you're going to need to focus. So that leads me to number four, which is the need for additional resources. Now, that's an easy one because it leads straight from number of patients and into it, but it may not always be that. You may have, like I said, you may have a hazmat scene. What if it's environmental? All right, you walk up, there's a big crowd of people hanging out in the parking lot, and by hanging out, I mean they're all unconscious. Do we really want to walk up to that? I mean, I'm all for joining the party, but that's not really my idea of a good time. So I don't want to be the guy that walks into a hazmat cloud to try to pull people out and then winds up being part of the problem. I'll be dead body number 17, who knows? So that would be a need for an additional resource. Call out the fire department and the hazmat guys with the monitors, and they can sit and figure out why everybody's having a sleepover in the parking lot. Three could be a triage situation, but you still have to eventually take care of all three, and there's only one of you, two of you at best if you're on a truck. But your need for additional resources is there. So that's four things. All right. Then you want to figure out what happened. So your MOI, which is your mechanism of injury, and your NOI, which if it's medical, that's what that would be. It'd be the nature of illness. In other words, you called me because your chest hurts. Great. That's your nature of illness. Or, oh, look, you decided to play chicken with a tree and you lost. So that's your mechanism of injury. Could be person versus tree or a person versus steering wheel, person versus ground, that kind of thing. And then the last thing you want to do, and you'll do this on every call, is you're going to assess the need for C-spine. It doesn't mean they're going to get a collar. All right, not everybody gets a C collar, but everybody at least gets the assessment for it, because if it's trauma, there's a high risk that they need a C collar, especially if it's trauma that's worthy of calling 911, like a car wreck or somebody getting thrown off a building or taking bath salts, trying to fly and figuring out that gravity still works. These things are probably going to need C collars for it, but even on the medical side, let's say it's an elderly patient, 80-year-old lady, and she has a stroke or a syncopal episode where she just kind of passes out for a second and she falls. Even from a standing position, she could still do some damage. What if she caught her head on something on the way down? The call is very much a medical, it's a stroke, but you can't rule out the possibility of trauma. In the real world, that's a huge thing. Now that is something that we're not going to do to you in class. I'm not going to give you a single scenario that makes you try to take care of trauma and medical at the same time. For class, you're always going to get a single issue that you have to work through your assessment with. Because we mostly want to see you use your assessment and do whatever treatment for whatever issue we give you. I'm not gonna give you some off the wall, tons of curveballs, even trip up a paramedic level scenario. I don't like gotcha moments. So we won't be doing that. But that doesn't mean that in the real world you may not come across a guy that was driving down the road at 80 miles an hour, had a hypoglycemic episode, hit a tree. So now you got massive trauma, caused massive bleeding, which led to traumatic arrest. So you've got a diabetic getting CPR with a tourniquet and all kinds of other stuff on, and I'm not doing that. That doesn't do anything for you. So that's your scene size up. All right, those 6 things, get them in your head, count them off on your fingers is a good way to do it. It's the way that one of my other paramedic partners would always try to teach it. Is just know you know 5 fingers and an extra thumb. That's your scene size up. So name them off. All right, now we actually just went through a whole bunch of slides by talking about that. So let's see. This is where they're talking about the MOI. Blunt trauma versus penetrating trauma. If it's blunt, that's where it didn't really break the skin. So think about getting hit by a 2x4. Penetrating would be things like bullet wounds, stabbings, impalements, those kind of things, anything that breaks the skin and goes in. Both of them can cause serious injuries to your organs. All right, not it doesn't have to be penetrating to mess up an organ, and we'll talk more about that, especially when we start getting into the trauma module, because you're going to see how getting hit, being in a car wreck, for example, what can your seatbelt do to you? Your seatbelt is fantastic. It holds you in place so that all those safety engineering devices and feats of accomplishment that are built into your car will actually work for you. But that doesn't mean the seatbelt won't hurt you. Just like it doesn't mean your airbags won't hurt you. It's just the damage they do is less than what would happen if you didn't have it on. All right. So the importance of your MOI and NOI, depending on whether we're talking about your medical call, trauma call, whatever, it's all right. It's just this step is trying to figure out what happened. Why did you call 911? This also is when you get a real good determination of how bad your patient might be. All right, there's a couple of things that you're going to consider here that will determine whether or not you can, we call them load and go or stay and play. If it's a bad call, we load and go. We as quickly as we can. It's like, all right, we're gonna work. We're not gonna do it here. We need to go. So you put them in the truck and you do what you can on the way. Stay and play, that's more for your stable patients. Say like somebody was skateboarding and twisted their ankle, that would be a stay and play. You can do everything on the scene, take your time, then put them in the truck and go. So knowing what your MOI and NOI is and knowing what that entails will help determine things. Now in the class, everybody will be a high priority for transport. I'm not going to give you the twisted ankle. I'm not going to give you a whole bunch of crazy stuff, but I'm going to give you a critical patient because I want to see you go through your entire assessment. If you show up on a scene and somebody just rolled their ankle and that's it, and you can tell by the MOI that there's really nothing else, they just fell from like 6 inches off the ground, you'll see where parts of your assessment really aren't necessary. So that's not what I'm going to give you because I want to see y'all go all the way through it. Make sure you wear your PPE. Gloves are a mandatory minimum. All right, you will at least wear gloves on every single call you go on. Now, remember that the gloves aren't just to protect you, they're to protect your patient as well. Because let's face it, EMS personnel aren't immune to things like hepatitis, right? We have people in the field that have it. We have people in the field that might even have HIV. We don't know. We don't test for that. So wearing those gloves is very important. It's important for you, it's important for your patient. If you have multiple patients that you're bouncing between, then you're going to want to change gloves with every person because same thing, even if you're clean, you're wearing gloves to protect you from patient A. You want to make sure that you don't contaminate patient B with patient A. So put a new set of gloves on. They are getting to a point now where, as you can see it in the picture, the eye protection is becoming more common, especially with things like COVID being out there. You know, if it's droplet based and it gets in your eyes and you don't even notice that it got in your eyes because it doesn't have to be some giant loogie to count. Sorry for that mental image. But, we may not even realize we got droplets in our eyes, and that's enough to infect us. And I'm not trying to scare you. I just want to give you the importance of why we wear PPE on every scene. So don't get complacent with that. If you do in class, that's an automatic failure. So that needs to be step one, BSI, which is your PPE, and scene safety. This just tells you standard precautions are the ones that you're going to use every single time. So at least gloves are standard, right? That's why it's called that. You have other PPE. We can gown up if we want to. We can look like we're going into a hazmat call. And if you're going to be delivering a baby, you're going to want to do that because that gets real messy. But you don't want to go to the guy that's having chest pains looking like you're walking into a hazmat scene. It can alienate your patient. So pick a level of PPE that fits the call you're dealing with. And just know that just like scene safety can change, so can the level of PPE you decide to wear. If you walk in to epigastric pain, stomach pain, you walk in and you see the person just projectile vomit right when you open the door, you just close the door. Like, you know what? I think I need a gown. Go get a gown. That's all right. that kind of thing. So don't think that you can't change what you're wearing. Vice versa. You walk in expecting projectile vomiting, you show up and everything looks pristine and there's no real problems. You can dress down. Um, it's not it's not uncommon to have people tell you that they've got something to get you to hurry up because they just want to hurry up and get to the hospital. We've had people call and tell us they've had massive stomach aches and diabetic emergencies, and we show up and there's absolutely nothing wrong. They just wanted to go see the doctor for something, and they figured if the ambulance brought them, it would save them the time in the waiting room. So it doesn't, by the way, but people will try that. Just make sure you don't get complacent. Don't start assuming that will happen, but it will. All right, we already talked about determining the number of patients. How many patients can we fit in an ambulance if they are non-ambulatory? Yeah, technically we can do two, right? We can put one on the stretcher and we can lay one across the bench seat. The bench seat, the way the seat belts work is you can strap a longboard there if you need to. Remember, you still got to have somewhere for your paramedic to sit. So you've got your stretcher, and if they're non-ambulatory, meaning they can't walk, um, they're not going to be able to sit. Usually, they can't sit upright. So you won't be able to put a non-ambulatory patient in the captain's chair. You won't be able to sit two non-ambulatory patients on the bench seat. They're going to be laying down. So two non-ambulatory. You could put three patients in there, but it's highly not recommended because that means that one paramedic is okay. So really, so I haven't seen civilian ambulances do that. I guess it makes sense. I just haven't seen the civilian ambulance with the connections for that. Military, yeah, absolutely. They've got your line like stacked up besides and everything. That's pretty cool though that they've got that. Where do you work? What area? Okay, okay. Yeah, I don't think the ones on the Gulf Coast have it. And I know that the other companies don't. Um, but I know that they can do that. That is a possibility because like I said, the ambulance the military ambulances, yeah, they don't give a shit about comfort. If you need to, if we got to fit people in there, we'll cram them in. Triage has its own chapter. I'm not really going to worry about that. This is what we do with mass casualty incidents, where we have more patients than what we have responders. If we can't do a one-to-one match, then we have to start picking and choosing who we work with, who we work on. That's where triage comes in. If all they have is a paper cut or a sprained ankle, then we're not going to put their treatment above the guy that's about to go into cardiac arrest. We're going to try to stop that guy from going into cardiac arrest. So that's where triage comes in. It's basically just decision making to make it where we know who to work on first and who can wait. Talked about your additional resources. It's not just extra paramedics, even though that is a big part of it. All right. So now for your primary assessment. And here's where you get your first real decision of what you're going to do for your patient. At this point, you have painted your scene. You know things are safe. You're wearing your BSI. You have ancient ambulances. Um, once you're ready to actually start working on your patient, this is where you're going to be at. It's the beginning of your primary. This is your life threats. All right, and there's two categories that we're looking at in here. We have your LOC, which is your level of consciousness, and your ABCs. Anybody that's ever taken CPR, you've heard of ABCs before if you've taken it from far enough back. They changed CPR to start with the letter C, but the letters mean the same thing. So airway, A is airway, B is breathing, C is circulation. We need those three things to survive. So those are the three things that we're going to look at as primary life threats that we need to address. But we're only looking at the life threats at this point. So I don't want you thinking that when you get to circulation, you got to start patching paper cuts and all that stuff. It's literally they don't have an airway, which means they can't take a breath. So I should probably fix that now, because if I go through my entire assessment with them not being able to breathe, I'm going to be dealing with a dead body by the end of it. So that's what we're going to deal with. For B, we're worried about the actual ability to breathe. So it's not about, like for A, it's about getting air movement from the mouth and the nose to the lungs. B is more about the respirations and getting the gas exchange to happen. So we want to make sure that we have that. And there's a couple ways that we'll check. C is your circulation. That is where we're referring to the ability of the blood to move around the body. And so there's a couple things we'll check there. We'll check the pulse, make sure we have a pulse. We'll check to make sure they're not bleeding out or bleeding in if it's internal, and a couple of things like that. But we're only worried about the massive bleeds. We're not worried about, like I said, paper cuts, broken bones, none of that stuff. That'll all come later. You do want to form a general impression at this point. This is when, because at this point, you're just starting to lay eyes on your patient. Your general impression, they put a lot into this, but really it just boils down to one of two things. They're either sick or they're not sick. And that is your professional opinion. When you walk in, if they're sitting there and, they're just kind of like cocked back with no signs of trauma, no signs of distress, and they're like, hey man, my stomach hurts, I'm going to go to the hospital. Probably not that sick. All right. But if you walk into a chest pain call and the guy is sitting there and he's kind of propped up and his skin's cool and clammy and he's kind of breathing out of his mouth, his eyes aren't able to focus on you, and he's sweating, clutching his chest, and looks like he's about to die, that would be a poor general impression. That would be he needs help. Okay. And you're going to get both ends of the spectrum. You're going to get the guy with nothing wrong that's going to try to tell you that the world's ending. And you're going to get the guy that looks like he's about to die that's going to try to tell you that nothing's wrong. So that's why it's not about what your patient tells you. Your general impression is, what do you see? You make a note, like it says, of age, sex, and race, because those matter. All right. It doesn't matter with their treatment per se, even though in some ways, it's particularly to the age, it does. But some illnesses like sickle cell are predominantly in African American races. So if you show up and you're looking at your patient, and depending on what they called you for, if they're African American, that brings sickle cell pretty close to the top of the list as what could possibly be wrong with them, depending on what they, like I said, what they called you for. Sex, what do you think that matters? And we'll use chest pain as an example. If you walk into a chest pain and you see a woman versus a man, what do you think the difference is there? And if you don't know, that's okay, because we're going to talk about it when we get to cardiac.
Don't heart attacks present differently in women?
Yes, they absolutely do. So think about what you normally hear. When somebody tells you the classic signs of a heart attack, it's tightness in the chest, radiates down the left side, that kind of thing. For women, it's more epigastric pain. So the pain is more centered. It's a little bit lower, not stomach pain, but kind of closer to the bottom of the ribs, around where the stomach would be, but just a little bit above it. And it's more centered. That whole out to the left side, radiating down the arm, women can feel that, yes, but they tend more often to present with the pain being localized. So if you don't know that, then when you go to a female with chest pain or a female possible cardiac patient and she tells you that she's hurting in the center, kind of below her breast a little bit, you're going to think GI pain, right? GI stomach cramps or something like that. And you're going to completely miss the fact that she's having a heart attack. So that's where you want to kind of keep that in mind. Again, look at their level of distress. The guy that's just sitting there like nothing's wrong tells you, oh yeah, it's a 10 out of 10. Ow. What? The nonverbals matter a lot more, right? His level of distress actually matters. And then the appearance. If they look like they're about to die, they're probably about to die. And we don't want that to happen. As you approach, make sure the patient sees you coming. The last thing you want to do is scare the crap out of somebody. Note the patient's position and whether the patient is moving or still. So at this point, like I said, you're coming up to your first decision. So think back to with CPR. We're gonna set EMT aside for a second. When you walked outside, and your CPR instructor says, all right, you walk outside and there's a guy laying on the ground, he's unconscious. What's the first thing we do?
Do the tap and shout to see if they're alert.
Yeah. So you're basically gonna check his level of consciousness, right? Which is right here. All right. So we're gonna assess your level of consciousness. And like I said, think about this from the CPR standpoint, because I know you guys have already been through that. Hey, are you okay? And you do the sternum rub or the shoulder pinch, slap the bottom of the foot if it's a baby, any of that kind of stuff. If they're unconscious, the next thing we do, what Jeffrey put in, is you check for a pulse. That's the first thing you do. Now, when you think about your primary assessment, we already said that ABC, right? C has your pulse, and that's at the end. This is the exception to that. If they're completely unconscious, immediately check for a pulse, because I don't want you assessing the airway and breathing of a dead guy. So if they're unconscious, check a pulse. If they don't have a pulse, what do we immediately do?
Don't you start CPR?
Yes. And we start CPR starting with compressions. All right. And that's why I want you to get used to checking the pulse of an unresponsive patient, is because whether you're going to do ABC or CAB is determined by if they have that pulse. If they're unconscious without a pulse, you're going to start compressions immediately. So now you're going down the CPR route. This whole assessment that we're going over tonight gets put on pause while you work CPR. If they do have a pulse, great. Then you continue on. So you're going to do your ABCs and then continue with your assessment. But what I see a lot of times I see this happen, and I want to try to steer y'all away from this mistake early, is they're unconscious. All right, so like I'll have a student going through their assessment. They get through their scene size up fine. They get to their primary, and they're like, all right, his LOC. I'm like, what are you checking? They're like, well, I'm going to check for AVPU, which we'll talk about in a second. It's alert, verbal, painful, or unresponsive. Like, okay, cool. Your patient is unresponsive. He does not respond to anything you do. And then, okay, so I'm going to look at his airway. So, okay, open his airway. So they open his airway. Then they're like, okay, is he breathing? I'm like, no, he is not breathing. How long are you going to check this? I'm like, I'm going to look for 10 seconds. Oh, okay, all right, 10 seconds. All right, still no breath. What are you going to do? Then they try to start bagging, because that's what you do. Then they're like, okay, I'm going to check for a pulse. I'm like, oh, he doesn't have a pulse. What are you going to do? Compressions, right? But now you've taken a long time to get compressions going. And the studies show that compressions is actually the by far most important part of CPR as far as the actual hands-on portion of CPR goes. AED is equally important if you can catch it fast enough. But again, if you don't catch the no pulse with the unresponsive, by the time you do get it, you've wasted precious seconds. And especially if you're new and you're not really moving through your assessment that fast, it takes you that much longer to get to the point of doing compressions. And not to mention, you've thrown off your whole routine because you did it all backwards. So I do want you all to remember that. If you can lock that away for your primary, is that when you get to it, LOC, if they are unconscious, check a pulse. If they don't have it, immediately start your CPR. And because CPR is basically cause and effect. We check for something like a pulse. If they don't have it, we immediately provide it. Even when we're doing CPR, you've done your 30 compressions and then you get to A and B. You open the airway and you're looking and listening for breaths. You don't see any, so you're going to give your 2 breaths. We only give it if we don't have it, but we give it immediately upon finding out we don't have it. And that's the case for a regular primary as well. Let's say that he's unconscious. So you take a pulse and he does have a pulse. Cool. We don't have to do the compressions, but you move on to now you're going to start your ABCs. You get through A and you find out he's not breathing. So you're going to breathe for him. You didn't have to do the compressions. You're not doing CPR, but you're still providing an immediate action to provide one of those 3 things, either airway, breathing, or circulation. That's how it all kind of blends together. It kind of starts to make sense. Do we have to activate? What do you mean by activate the AED? Do you have to use it? No. It's fine. I want to make sure I'm understanding what you're saying. If you want to unmute, you can unmute and talk. I don't want to answer your question wrong. So when we get to the cardiac chapter, the cardiac emergencies. Okay. I was going to say when we get there, we will go into the AED. Yes, we do use it as EMTs. Um, we don't not every time will it shock because it's only looking for two specific rhythms that we'll get to those. We'll talk about them. The only reason that I got tripped up by your question is because the term activate, like when we teach CPR, we're telling them to activate 911, which no, you technically wouldn't do that because you are 911. But yes, you would use the AED. If you wind up going down the cardiac arrest route, then yes, absolutely. We're going to do the full blown, just like you learned in CPR. You're going to do CPR. We'll bring in the AED, which you should have on you. Anytime you go into an alter level of consciousness call or cardiac arrest, or not even cardiac arrest, but just cardiac in general, bring your AED. Because even if they're not in cardiac arrest yet, God forbid, if they crash on you when you walk in the door, you don't want to have to be the one that has to run back to the truck to get the AED, right? So we'll carry that with us. All right. So anyway, your categories for level of consciousness at this point, there is the Glasgow Coma Scale, and we'll get to that. But at the early stages, because right now it's a quick overview of your patient, trying to figure out what we're dealing with. We use the term AVPU. So A is alert, V is verbal. Let me get to the right screen here. There we go. Okay. So A is alert, V is verbal, P is responsive to pain, and U is unresponsive. These are the four categories that we're going to kind of put patients in all the time. If they're alert, that means they're like me and you right now. We're up, we're talking to each other. They might be in pain, they might be pretty critical, but if they're able to respond to commands, if they can track you with their eyes, that kind of thing, they're alert. As we start going down these levels, I want you to kind of think of it as if they're going to sleep on you. So responsive to verbal would be where they're kind of starting to nod off. They're getting their heads bobbing a little bit. Their eyes are closed or whatever. But if you shout at them, they'll kind of, whatever. That would be responsive to verbal stimuli. You can get a response, but it's not a good response, right? If it was a good response, it would be alert. If shouting at them doesn't do anything, then we check their responsiveness to pain. That's where like what you learned in CPR with the sternum rub, the shoulder pinching, those kind of things. That's we're checking their responsiveness to pain. If they are responsive, then they're going to kind of grunt. They might recoil, pull away from you, that sort of thing. And then unresponsive means that you get nothing. There is as far as responsiveness goes, they're as dead as a doornail. They're not going to respond to pain. You can shout at them. Usually in the unresponsive stage, their reflexes are out, which means like their gag reflex won't work, which is important to note when we start talking about airway adjuncts, um, that kind of thing. All right, so these are just kind of different ways you can test for painful stimuli. You can press down on the bone above the eye, pinch the neck, or not the neck, I'm sorry. Well, yeah, this one shows neck. You can pinch the traps kind of at the top center of the shoulder, close to the side of the neck. You can pinch there. You can pinch the earlobe. If it's a child, like a baby, like a really young child, you can take your finger and kind of rake the bottom of their foot. That's more of a reflex response. Doesn't really cause pain, but it has the same The same effect. Oh, that was unmuted. Let me mute y'all. Okay. All right. So anyway, if they're alert, they're talking to you. If they're verbal, then when you shout at them, they'll respond. When they're painful stimuli only, you're gonna have to do one of these. And then unresponsive just means unresponsive. Now to add to that, we have what's called orientation as well. So if I were, think about it when we talked about medical ethics, and I know that Brad did y'all's medical ethics class, but you had to learn that your patient had to be alert and oriented. So we always say A&O times 4. These are the 4 things that they're doing. If they're alert, then we're going to check to see if they know where, when, who, and basically what they are. If they're not alert, then these won't matter, right? Because if a person's half asleep and all he can do is grunt at you, he's not going to be able to say the answers to these. But this is for making sure that they don't have some kind of a altered mental status. Because you can be up walking around talking to people and still be completely out of your head. So that's what this is checking. All right, so then we're going to identify our life threats. These are some conditions that can cause sudden death. You have airway obstructions, right? This blocks your A. Respiratory failure, respiratory arrest. These are problems with B. And then we have shock, severe bleeding, primary cardiac arrest, sudden cardiac arrest, traumatic cardiac arrest, so on and so on. Those are problems with C. So you can see now how that's what we're checking. So we start off with A. I want to make sure that I have a good route from mouth and nose all the way to the lungs. I don't want to have any obstructions in there. And that can be obstructions from a piece of steak. That can be obstructions by the airway clamping down from an allergic reaction. Any of those. That's going to be problems with A. Now that I know that I've got my airway, I want to make sure that the breathing is happening. So air's got to not just have a way to get in, it's got to actually be moving. And so that's where your respiratory failure, respiratory arrest is. Respiratory failure does not mean that you're not breathing. Respiratory failure means that you're really, really struggling and it's not enough to sustain life. Respiratory arrest is where you are completely done. Like there's no breathing. You would bag both of these, but at least respiratory failure means the body is still trying to breathe. Shock, we will go into heavily in depth. There's a chapter on that. There, I'll also give you guys a lecture at your boot camps. When that day comes, I'll be at your boot camps for that. Severe bleeding, we're talking about hemorrhaging, not your paper cuts, not even some venous bleeds. We're talking about like arterial, shoot it across the room like Spider-Man kind of bleeds. And yes, some severe venous bleeds, and we'll have chapters on that as well. And then cardiac arrest is a definite sudden, life or death incident. All right. So this slide basically just tells you what I told you about your unresponsive patient. Most of the time, if they have a pulse, you're going to do ABC. If they don't have a pulse, then you're going down the CPR route, and that's what switches it to CAB, which is how they teach it to you when you do CPR classes. All right, so let's talk about the airway. Short and sweet. We just need to make sure the air can get in and out. All right. Now, there's a couple of things to do about this. First of all, we have 2 ways of opening the airway manually. We have a head tilt chin lift, and we have a jaw thrust. And we're going to use them depending on what's wrong with our patient. In other words, one's good for trauma, one's good for medical. Which one do you think we would use for trauma?
Jaw thrust.
Yes, the jaw thrust. Because a head tilt chin lift, by nature of the movement, hyperextends the neck. If they have any kind of neck trauma, we run the risk of breaking their neck. We don't want to do that. The jaw thrust as an airway sucks. I ain't gonna lie to you. It's a crap airway. It's hard to do. It's hard to maintain. And it's just unfortunate that sometimes is the only airway you got. If you know that somebody's possibly hurt their neck, then that's it. And it is better than nothing. But it is not as good as the head tilt, chin lift. So if you think you can do the head tilt, do the head tilt. That's much better of an airway. But the problem with these, for both of these, is that if we let them go, the minute you let them go to continue your assessment, you lose them, especially the jaw thrust, because you're lifting the jaw up. The minute you pull your fingers off, the jaw just falls right back into place. So we have to make sure that we do something else after that in a way that makes our airway stay open at all times, and that we call that a patent airway. All right. And so we have a couple of devices that we'll use, and we'll show you how to do that. We use an OPA, which is an oropharyngeal airway, and an NPA, which is a nasopharyngeal airway. The OPA, to me, and this is just my own personal opinion, the OPA is the better of the two. It does a better job holding the tongue off the back of the throat, which is what they're designed for. They're only really good to keep the tongue up, so that your patient, if your patient is snoring, like when you walk up to them, if they're in an ultra level consciousness, they're not alert, they're somewhere in that VP range. If their tongue is relaxing on the back of their throat, when they breathe, they're going to snore. You're going to hear the tongue kind of flapping. That's what the head tilt chin lift fixes. That's what the jaw thrust fixes. That's what those two airways fix. And those two airways keep it that way. Because remember, if you let go of the patient, you lose what movement you did. If your problem is anywhere else other than the tongue, those devices don't work. There are some other ones that you can use as an EMT, but if you're dealing with airway problems at that level where they're deeper down, probably definitely want to get a paramedic. All right. A lot of places down here, you ride ALS trucks, you already have a paramedic. Fantastic. If you guys take this training and you decide to move to Denver or New York or something like that, the massive nationwide shortage of paramedics right now means that there's very few agencies out there that staff ALS trucks like they do in the South. So what they do is they'll staff a bunch of basic trucks, and then you'll have paramedics in sprint vehicles who will go from one call to the next as they're needed. So that whole assessing the need for additional resources, especially if you need ALS support, that is huge in those places because they may not be on the truck with you when you arrive. So if you're fighting to get an airway and it's something wrong other than the tongue, you might want to get a paramedic out there. So for your responsive patients, if they're talking to you, they have an airway. And usually if they're talking to you, they are able to breathe as well because they have to take the breath to project their voice. That sounds like very much common sense, but it's funny because if the registry would understand what they're teaching, they wouldn't require you to say out loud, all right, my patient's talking to me, he has an airway. You'd be surprised because if you don't say that, they fail you. And it's like, well, wait a minute, you put it in the class that if they're talking to me, they're good. So make sure you say that. All right. If they're unresponsive or they have just like a decreased LOC, or if there's a potential for trauma, you're going to have to maintain an airway for them as best you can. If they breathed in superheated gas because they were in a structure fire or some kind of a chemical spill, something like that, the resulting swelling in their throat is going to be a major problem. And that's not something that we can fix. That's not something that the head tilt will fix. It's not something that the OPA or NPA is going to fix. That's something that a paramedic will fix, even if it means a surgical airway. So again, those are the things that we want to use. And normally that's not the case. Normally the biggest problem with unresponsive patients is just their tongue relaxes. So the airways that we use typically will work. Even if like if a paramedic shows up, they're actually training paramedics now not to jump straight to the ET tube. Even like if a paramedic's leading the scene from step one, they're probably still going to start with an OPA or an NPA and then progress their level of airway protection as needed. Because setting those advanced airways takes time. They can be missed. They can cause damage to the throat. And for the longest time, they were teaching paramedics that they had to always do that. Paramedics got it in their heads that they had to always do that, and that wasn't the case. And so they would spend so much time trying to get that airway, especially if they missed, because not all throats are created equal. Some of them are actually kind of hard to get a tube in. if they missed it or they caused damage, they might have actually made the airway worse. So they're teaching now that's actually a skill that was always BLS and was always overlooked and everything, but y'all always had it. Now even the paramedics are grabbing the OPAs and the NPAs first. Signs of obstruction in an unconscious patient can be obvious trauma. Like I said, it doesn't necessarily have to be the piece of steak. It can be blood. It can bleed. It can be an upper GI bleed, vomit. It can be anything that can come up from the stomach. It can be anything that would come from an injury. It can be the throat itself. If the airway starts to swell, it'll swell itself shut. And then the real fun one, which we'll talk about when we get to CHF, is it can be coming from the lungs themselves. And when the crap is coming from the lungs themselves, that's a pain because there's no airway that stops that, right? Even if a paramedic put a tube down somebody's throat, it's still going to be coming from the lungs, which means it's going to clog the tube. So I will teach you guys something that you can do to combat that. Just a tool for your toolbox. So when you come out of class, you go to the field, at the first thing you see, holy crap, a CHF, you can be like, aha, I got this. Rob taught me something. And you can save that person's life. All right, let's take a 10-minute break. It's 7 o'clock. Well, it's a little bit after. But we'll get started back at 10 after. We're going to pick up with breathing and then move on from there. For those of y'all that aren't walking away from the computer, how's everybody doing? Y'all can unmute. We're just chatting if anybody's here.
Doing good, Bob.
Good.
Good.
Anything new? I don't get to talk to y'all very much, especially since classes started. So I always want to check in and see how things are going.
I'll be graduating college in May.
What are you going for?
Management with studies in psychology.
You know, it's interesting. I'm actually taking college classes right now as well to try to pursue nursing school. To up I have my LPN, but I want to get my RN. And one of the classes I'm taking right now is actually abnormal psychology. Have you heard that one?
That's cool. I don't think I can do nursing. I think that's, I don't know.
Yeah, jury's still out on whether I'm going to like it or not. The main reason I want it is because I want to pursue nurse educator and kind of add those classes to ARES, but I'm not much for working in a building all day. I like to be able to get out. It's one of the things I like about fire and EMS. So we'll see. Oh, I got you. I don't blame you, Kristen. You can unmute and just start hearing screams.
Hello.
How's it going? Yeah, congratulations, Letitia. I only know one person that's ever gotten that degree. I know I say it's common. It's not. necessarily what I meant, but I mean, for as often as I hear it advertised, I've only ever really met one person to do it. Was it a hard program?
Hey, Robert, I have a question.
What you got? Go ahead with your question.
Where is boot camp going to take place at?
We have multiple locations, so it really just kind of depends on where you're at. Where are you located?
Lafayette.
Lafayette. All right. So right now, the closest to you is either going to be Abita Springs to the east or Alexandria to the north, where that's actually where I'm at right now. I'm working on a Lafayette location, but I don't have it official yet. So I don't want to say that that one's up and then have to tell you that it's not. But we are working on it.
All right, thank you.
No problem. Yeah, your boot camp's not going to be until May, so we do have time. A lot can change between now and then. Really, getting a location set up isn't hard. It's just finding the location. It was challenging, but not okay. Yeah, I've always kind of been curious about that, about how hard the billing and coding was. Excuse me. I hate being unmuted for that. Thank you. All right, we're about to get back started. So we've talked about A, right? So that is all about making sure that we have the path from the mouth and nose to the lungs, make sure we have an ability for the air to get through. Everything we do in A has to do with that. So now we're going to start talking about B. Now that we have the roads, we want to make sure that the cars are going down the road. So once you've made sure your patient's airway is open, make sure the breathing is present and adequate. It should be within a certain age range, which remember when we talked about lifespan development, most of your adults are going to breathe 12 to 20 times a minute. And those numbers are pretty well locked in. Everybody typically agrees on those numbers, whereas, they kind of have some variance in other age groups, other vital signs, but 12 to 20 is pretty much set in stone. Now, if they have 11 or 21, that doesn't mean that we're going to suddenly freak out and bag them or anything like that. There is a little bit of a fudge factor there, usually about 4. So if they're between 8 and 12, that's okay. But we're going to pay attention to that because if they drop a little bit, then they're going to be too low. If they're sitting at 16, 18, something like that, fantastic. If they're in pain, what do you think their breathing is going to do? Is it going to go up or down? Yeah, it's going to go up. Usually when people are in pain, their vital signs climb. The reason they're breathing fast is because their pulse is starting to climb. And those two systems work together, which means that they kind of work against each other too. Yeah, pleurisy is a difference. And the reason being is because it hurts to breathe with pleurisy. So, but actually, you're still going to have a quicker breathing rate. What you're not going to have is they're not going to breathe that deep because taking a good breath, the bigger the breath, the more that lung is going to kind of grind up against the chest cavity because of that. Yeah, that's what you're going to see because they don't want to take a deep breath. It hurts for them to take a deep breath, but the body is still screaming at them to get oxygen. So they're going to start breathing faster. So you're going to have a faster breathing rate, but it's going to be very shallow because they're trying to breathe without raising their chest. They don't want that hurts them, so they don't want to do that. That becomes a problem in a couple ways. They're not going to get enough O2. They're going to start losing too much CO2, and they're raising their pulse rate. So a lot of times when we're dealing with that, we're going to do interventions to try to bring their breathing back down under a normal range and to give them enough oxygen that even though they're breathing a little more shallow, they're still oxygenating themselves. So the body's not going to want to hyperventilate as much. But anyway, okay, we'll get to that when we get to airway. But moving on, getting back onto the breathing. Couple questions you want to ask yourself is the patient breathing? Is it adequate? All right, like you said right there, that shallow, that's where you put context to your number. If I told you somebody's breathing 16 times a minute, can you really determine based just on the number if it's a good breath? It's a good range, it's a good rate, but no, you really can't tell because it's shallow. It could be super, super deep, which is a problem on the other side of it because it's not just about keeping a good O2 sat. You want to keep a good CO2 level as well. That even though we breathe that out, we call that waste. The body relies on it to maintain a certain pH, and so there's a balance to it. We don't want to get rid of all our CO2. That's a buffer system for us to make sure that our body is operating in the right pH, the right acid base level that's conducive to life. If we start to get too acidic, we breathe faster. Our body determines it needs to breathe faster so that we can blow off some of that CO2. If we are getting too alkalytic, then we slow our breathing, which builds up the CO2. CO2 is actually an acid, so that climbs us, or that brings us down the pH, kind of back toward the acid level. And I'm pretty sure we're going to talk about CO2 a little bit in this, but I don't want to get the CO2 is really mastered by the paramedics, but I want y'all to understand it. So we are going to talk about it. And then, is your patient hypoxic? So what's a big sign that somebody's hypoxic? Let me ask you this. What's the most common sign everybody always points to? What's the first thing that comes to mind when you think of somebody who's not getting enough oxygen, as far as like what you can see that's wrong with them? Okay, there we go. Yep. So I got 3 different answers, and absolutely. So the most common sign that we always look for is turning blue. We call that cyanosis.
Ye-
Cyan being like the blue color cyan. Um, that's what everybody thinks about. Now I saw some even a closer answer to a different version of this question, which would be, what's the first sign of hypoxia?
Oh, my computer. Oh, my computer.
What was that? I told you that. Okay, so the first sign of hypoxia, the very first thing, if somebody is becoming short of oxygen, the blue fingers, the blue lips, all that stuff, yes, that is very much a sign of hypoxia. And I want you to look for that, but don't get common confused with first, right, or early. Hypoxia, I'm sorry, cyanosis is actually a pretty late sign. You've been hypoxic for a while if you have the blue extremities, the blue lips, that kind of thing. Um, One of the first things you're going to see is higher anxiety. All right. Wheezing, not necessarily a hypoxic issue, that's an airway issue. And it usually means that your airway is constricted. So think asthma. Asthma is a constriction of the airway. That's a problem in A. That would be wheezing. But for the actual oxygenation and getting oxygen into the blood, getting CO2 out of the blood, that's what B deals with. When you first start to get hypoxic, you start to get anxious. Your vitals start to climb. You're like, I don't know what's going on. I can't breathe. And it just goes from there. Um, that's usually your first sign. The brain is the biggest baby organ in the body. It's the first one to complain when something goes wrong. The brain needs 2 things to function. It needs oxygen and glucose. If either one of those gets out of range, the brain is the first thing to complain about it, which means that you're going to see problems with the brain first. So altered level of consciousness, anxiety, those kind of things. You're going to see that before you see problems anywhere else in the body. So if you're looking at blue fingertips and blue lips, that means that they've been in it so long that the rest of the body is starting to complain too. The brain's been complaining for a while. The problem is a lot of people don't recognize that. And I'm not meaning y'all as EMTs, but just in general, you're going to find where you show up to somebody's house and let's say they're on home oxygen. All right. So the general assumption is that their oxygen is going to be good. But for whatever reason, it's not. They're not respirating properly. They're not getting the oxygen in their system, and they get anxious, and family member doesn't catch it. Um, yes, it can lead to some life threats. It can lead to long-term complications. We try not to let hypoxemia stick around unless they're some kind of COPD patient that needs to stay in a certain range. And even then, a lot of times we don't make that decision in the field. We just adjust our oxygen delivery to where it makes them look the most normal. And if that keeps them at 92%, which is a pretty good amount of hypoxemia, then so be it. But normally we want to keep them a little bit higher than that. And I think that's on this slide. So under normal conditions, we breathe through negative pressure. Picture when you're in an exhaled point before you take a breath, you have a certain amount of space in your chest and there's a certain amount of pressure in your chest that's based on the atmospheric pressure pushing in. It's all equalized. When you breathe in, your diaphragm drops, your chest wall rises. So you've created more space in your chest. And for a split second, you have a drop in pressure because you had X amount of air in there that was pushing out against your diaphragm, your wall, all that stuff. But suddenly you've made the room bigger. So that push isn't as strong, that pressure drops. When it does, the atmosphere outside of your body just kind of falls in. All right. So when you breathe, you're not actually sucking air in. or I'm sorry, you're not, yeah, that's probably the best way to put it. You're not actively sucking air in. It just kind of falls. It's a pressure difference. You got a high pressure outside the body that's equalizing that all of a sudden lower pressure that's inside the body. And that's how we get air into our lungs normally. When we breathe out, all of your diaphragm rises because you've relaxed that muscle. Your chest wall falls back to normal because you've relaxed that muscle. So you had all the air that was in the big space crammed into a now small space. So now the higher pressure is in your lungs and it pushes that air out. That's how we exhale. If for whatever reason your patient isn't breathing, we unfortunately can't like put a device in their lungs to pull air in to do that. So we have what we call BVMs, CPAP, all these different devices that we will literally shove air into somebody's lungs. Now the lungs and the chest aren't really designed to have air pushed in, but that's the best we can do. So you may have to do that. Absolutely. If you get a breathing rate and it's 4 times a minute, or like it says here, fewer than 8, you're going to have to bag your patient. We're going to use a BVM. You can use mouth to mask if that's what you've got, and that's usually better than a BVM. It's just I don't like, people don't like putting their faces so close to each other. So the BVM is better for safety, but the mouth to mask, like you saw in CPR, that is better for quality of air movement. But anyway, if they're not breathing good enough to support life, we're going to have to do that. And we do that through positive pressure. It sucks physiologically. If we're doing it for a long time, or if we're doing it the wrong way for a short time, we can start to cause some problems. No matter how good you are, if you're doing it for long enough, you're going to cause problems. It's just there's a little bit of a buildup no matter how good you are. But the worse you are at it, the faster you're going to get to that problem. So that's something else. A lot of people in our field if you're a seasoned EMT, what I see a lot of times is they'll usually throw the BVM at the new guy and say, hey, I need you to bag the patient. And that's actually probably not the best idea, but it's an easy job. And it's easy to the point where people that have been in it for a while, they'd much rather be doing their ACLS drugs or much rather be doing the code itself or something. And they feel like bagging the patient is kind of beneath them. But it very much can be messed up, despite how easy the process is. It can be messed up if you're not careful. We'll show you the right way to do it at boot camp. Make sure that you don't get complacent in your careers, and if you catch other people doing it, correct them. All right, because you can kill your patient with the BVM. You can make it to where CPR is ineffective. You can make it to where even if they got the drive to breathe back, they can't do it because of the damage we have done with the BVM. So again, not trying to scare you, very basic tool. It is possible to mess it up. So I don't want you to think that tossing it to the new guy and saying, here, do this, and I'm just gonna leave you alone and let you do it. It's probably not the best idea. Our goal for oxygenation is between 94 and 99. Now we used to always say everybody gets oxygen, 15 liters per minute, non-rebreather, just flood them with oxygen. It's not going to hurt them, blah, blah, blah. And yes, it will. This is also something that has changed recently. We have found out that over-oxygenation can kill the patients as well. So oxygen as a placebo, that's pretty much gone. You'll still see it. People still do it, but it's not a good idea. Anything over 100% oxygenation, the body can't deal with it. So because remember, oxygen travels in pairs, right? O2. If we over-oxygenate, the body can't completely process the oxygen. It winds up breaking it apart, but it can't absorb it. So you now have O1s that the body can't do anything with. They're called free radicals. They fly through the system and they're like wrecking balls. Every cell they hit, they destroy it. So the more we do it, the more cells we destroy. If we do it on a big enough scale, we can actually cause massive multi-system shutdowns, necrosis, all kinds of bad juju, right? So we don't want to do that. We want to keep our patients between 94 and 99 unless there's a reason for otherwise. There are a couple special cases. If they lost a lot of blood, if it's a stroke, COPD patients, we may not try to aim so high. Again, we just treat our patients, not necessarily our monitors. Because you may get a patient that looks like they're suffocating, and when you put the O2 sat on them, it tells you they're at 100%. Well, if you're looking at the number, you're like, oh, cool. Well, you don't need oxygen, despite the fact you look like you can't breathe. So this number is both set in stone and a guideline at the same time. It just depends on what patient you're dealing with. And as we go through the course, I'll explain to you guys every time we talk about something. I'll be like, all right, remember O2 sats 94 to 99. O2 sats 94 to 99, whatever. And then when we get to those special cases, I'll be like, all right, this is one of those times. Forget 94 to 99, just flood them with oxygen, because not doing so is worse for them than the free radical issue. But we'll get to those. Breathing should be effortless. So when you're looking at this, you should watch to see if your patient is actually having to struggle to breathe. We call it work of breathing. You shouldn't actually, unless you're working on a patient that just ran a marathon, you shouldn't actually have to see them struggle to breathe. So retractions, use of accessory muscles, nasal flaring, 2 to 3 word dyspnea, which is where they can't say a sentence without having to stop and take a breath. The tripod position is huge. You really see that a lot more than, I mean, it sounds dumb, but that is a common one. And the sniffing position. Labored breathing is an issue, obviously. Just remember, it shouldn't be difficult to breathe. Everything should move smooth. If you see every time they take a breath, if you see their muscles around their neck sink in and around their clavicles sink in, that's a problem. If you see their nose flare out every time they take a breath, that's a problem. The accessory muscles, seesaw breathing in kids. The tripod position is where they're sitting up and their hands are on their knees. And they're kind of leaning forward and they're gasping for air. It almost looks like they're in that baseball, the outfielder's position, but they're seated. Can anybody tell me why that is the preferred position for somebody who can't breathe very well? Nothing? Okay. The reason being is because when you're in that slightly leaning forward position as an adult, most of what we do for movement of our breath is in our chest, the chest rise. So if you lean forward, gravity is working with you, not against you. Try to minimize pressure and open up the lungs. Yeah, that too. Because if you're laying back, the weight of your chest is pressing down your lungs. So same thing. You're allowing gravity to work with you. That slightly leaning forward makes it easier to breathe. And then being propped up on your hands means that your core doesn't have to work as hard to keep you sitting upright. So you're relaxing the muscles that you wouldn't normally think you were even using to sit yourself up straight. And then you're letting gravity kind of help you take a breath easier. You're going to hear respiratory distress. A lot of times you get dispatched for shortness of breath. They may say respiratory distress depending on what your dispatcher knows or doesn't know. Distress just means that you have a harder time breathing. So you're going to see them actually having to struggle to breathe. And what is that noise?
So can I ask a question?
Yes, absolutely. Go ahead.
So is that kind of why I've heard before that they tell people who have panic attacks to put their head in their lap? I don't know if that's proper. It wasn't like an EMT or anything, but that's just something I've heard before. Would that kind of be like the same thing?
I'm going to field that question to the class because I've heard that is something that I've heard a lot, but I've never actually sat down and looked at the reason behind it. I don't know actually. If nobody knows that one, I'll Google it and get to you. That'll be something that I can look up and then talk about in the next class or after a break or something. That's a good question. Let me write that down. Why do people put their heads on their laps during a panic attack. I'm pretty sure it has something to do with the physiology of breathing. I don't think it's a psychological thing, but I'm not sure. I'll look that up.
Hey, Robert.
Yes.
As someone with anxiety, I can tell you that when you put your head down, it opens up your diaphragm, and so therefore it's easier for you to kind of breathe a little bit deeper, and it also helps to get your mind off of your surroundings.
Okay, so, but how far do you lay down? Because like me,
You don't, I mean, you just literally put your head between your shoulders, kind of like, your head between your knees, kind of lay onto your knees just a little bit, but raised up.
okay, so you're basically doing the tripod position. You're just leaning.
Yeah, you're doing the tripod position, but with people with anxiety, it helps them to get their mind off of their surroundings so that they can focus on their breaths.
Okay. All right, cool. There you go.
Thank you.
I know that like if I were to try to put my head on my knees, I wouldn't be able to breathe. I mean, I don't have much of a gut, but I got enough that would stop me from being able to. Yeah, I'm right there with you.
I always tell someone that's having an anxiety attack to put their arms on their chest and lean forward, because then that keeps them from going all the way forward.
Yeah, and that makes sense. And then like, just like you're kind of temple granding it a little bit too. You're hugging yourself. You get that security a little bit, even though it's just you. I could see where that would help a lot. So respiratory distress is just an increased effort. Respiratory failure is where the system is starting to fail. That's not a complete shutdown, but it's definitely not to the point where you can continue down that road. You're actually starting to get a wrench thrown in the engine at this point, and something's gonna stop. Something's got to give, right? If you don't fix it at this point, then respiratory arrest will start, and that's where they just stop breathing. And at that point, you were definitely bagging for them because they can't do it anymore. For circulation, there's a couple things we're going to look at here. Your mental status, I want you to kind of skip that because we already talked about it in your LOC. All right, but you're going to get your pulse and your skin condition. So you want to make sure that the blood's going around and around and that it's staying where it belongs. If they are perfusing properly, if they're not going into shock or they haven't lost a lot of blood, skin's going to be pretty much warm and pink, just like your skin is right now. If you lose a lot of blood, if you're having a heart attack, if you're going into shock for whatever of the 7 or so reasons that people go into shock is, usually the first organ to lose blood flow is the skin. And I mean, it's kind of a good thing because you can see it, right? That's an early sign of shock, is that cool, clammy skin where they're pale. But at the same time, it's kind of a problem because, first of all, you do kind of need your skin. There's a lot of functionality to that. Secondly, if you're the EMT and you see cool, clammy skin, well, crap, it's going to be one of those calls, that kind of thing. We don't want to be, I don't like seeing cool, clammy skin because I know that I'm already behind the curve on shock. Because that's one organ the body's already written off at that point. So you're going to assess your pulse. Can anybody tell me what the pulse range for an adult typically is? Well, no, well, C is where we're checking it, yes, but what's the pulse range? Minimum pulse range to maximum pulse range for an adult. There it is, 60 to 100.
Yeah. Stop.
What song was that? Was that Barney? Tell me that was Barney. All right, anyway. 70 is just pretty common. You're going to see 70 to 80, but the typical range is 60 to 100. It's a little bit more inclusive. If you don't feel a pulse at all, start CPR. Now, that being said, if you don't feel a pulse in the wrist, are you going to start pumping on the chest, or do you want to check the pulse somewhere else? Right, the carotid. So if you, I personally am a fan of checking both at the same time, because there's a couple of things as you go through your career you're going to kind of pick up. If you check the carotid and the radial at the same time, first of all, you don't waste time with just the radial, because if you're going to check the pulse for 10 seconds in the radial and you don't feel it, that's 10 seconds wasted, because you're going to have to check 10 seconds at the carotid. So I check them both. Unless if the patient's awake and talking to me, I know I have a pulse. So I'll just check a radial. If it's an unconscious patient or somebody that's kind of stuck somewhere in between in the verbal painful range, I'll check both. I may not expect to get a pulse in the radial. I do hope I get one at the carotid, because if it doesn't, then that really sucks. That means I'm doing CPR. But I should feel it. They should feel similar. They should be in sync. They should not. One should not be significantly less than the next. It shouldn't be. There shouldn't be an actual lag that you can. Not one that you would typically perceive between the carotid and the radial, that kind of thing. So I like to feel both. If I feel anything other than a simultaneous beat between the two, there's something wrong. All right, you can check a couple other places. Somebody, y'all name off a couple of other places that we can check a pulse around the body. So we have the radial at the wrist and the carotid at the neck. What else do we have? All right, so we got femoral pulses. I have a problem finding femoral pulses. I don't know personally. I just suck at it. I really do. I can find every damn pulse in the leg and the foot, but I can't ever seem to find the femoral artery. Don't tell Mike I said that. But that's my hard one. So when I do find it, I definitely want to mark it. So yeah, you're right. I don't want to be digging around in people's crotches trying to find that pulse again. You have the top of the foot, which is called what? Anybody know? You can't find yours in the foot. I've actually always had pretty good luck with those. It's not medial unless I'm the one that's mistaken. It's the pedal, like a bike pedal. Pedal pulses on the foot. What about the knee? What's the pulse in the back of the knee called? Okay, yeah, so there's the full name for the foot. What's the one in the back of the knee called? Good. You're on it. Excellent job. All right. So we're going to assess their skin color. Skin color is, yeah, you spelled it right. Skin color is the biggest determining factor for shock. It's one of the first things you're going to see when a patient like actually see as a sign when somebody goes into shock. Vital signs being different. Obviously, you can't see a vital sign, but you can measure it. So, but you have to actually measure it. You can see skin from across the room. When circulation leaves the skin, you go from warm and pink to this white pale. If you're African American, you don't turn white, you turn ashen. You start to look kind of gray. So it just depends on what your normal skin color is. Skin temperature changes as we get older. Typically, we all center around 98.6. The older we get, the more we really get stuck in that 98.6 range. If you're a baby, you're on 101, 102 degree temperature. Okay, that's a fever. If you're 40 years old and you run a 102, 103 temperature, you need to go to the ER and get dunked in a bucket of ice water, because that's enough to really make you have a life threat. Other abnormal skin temperatures, you have cool if you're hypothermic, cold clammy skin where they might be not hypothermic, but their skin is just not able to maintain its temperature because there's no blood flow to it, right? And again, that falls down into the hypoperfusion, which hypoperfusion is the nice fancy word for shock. Your skin, dry skin is normal. Skin that's wet, moist, excessively dry, and everything can suggest a problem. It just depends on what it is. If you are by yourself, if it's just wet, it could be just sweat. That's not a big deal. But if you're cool and clammy, right? So you're not just wet, you're wet with a discoloration, something of that sort, then it becomes an issue. It can be that you just don't have good blood flow. It could be that you're going into shock. It could be hypoxia can cause it because the body is saying, I don't have enough oxygen in my blood. So I'm going to have to make sure that all the blood goes where it's needed. Skin's going to be the first. Skin gets the short end of the stick. It's the first organ to start losing blood flow, followed by the digestive tract. All right, your cap refill. If you guys, if you guys get to meet Trevor at your boot camp, you should ask him what he thinks of cap refill. If you want to hear a guy just go completely postal for 30 minutes, just ranting about cap refill and all the problems with it, he'll do it. And it's funny. It's like he gets a little eye twitch, and I'm sure he's going to listen to this recording too. But yeah, I like messing with him. I always try to set the class up for that. But anyway, textbook, you should get like a 2-second refill in the color of your skin, but there's so many things that mess with that it's probably the most unreliable, biggest waste of time vital sign that you're ever going to check. So we don't really bother. Now, I'm not saying you shouldn't do cap refill. There are times when you might want to or whatever, but I don't want you to get hung up on the 2-second rule. All right. It's kind of like dropping food on the floor. The rule is however long it takes you to pick it up. 5 seconds, 30 seconds, 30 minutes, probably won't go that far, but you know what I'm saying. Where cap refill has a purpose is in trending. So if you show up to somebody and you check their cap refill at the beginning and let's say it's 3 seconds, that may not be a problem. It's more than 2, but it's not that bad. But then 5 minutes in, you do a reassessment and you check it, and now you're at 4 seconds. And later on, you're at 5 seconds. You can kind of see where that's not a good trend, right? It's taking longer to get the blood flow back. So cap refill is a trend, pretty good. Cap refill with a 2-second rule in mind is just a waste of time. Actually, it's not on the skills. The registry took it off. That's not a vital sign that we will check off. It's just something for you to keep in mind. Yeah, it can be an indication of dehydration and artery disease. But again, I don't want you guys to get hung up on the 2-second rule. That's the big thing. Because if you're cold, it's going to take longer than 2 seconds. If you have low iron, it's going to take longer than 2 seconds. If you're female, it's going to take longer than 2 seconds. If you're older than 10, it's going to take longer than 2 seconds. If you're human, probably going to take longer than 2 seconds. You know, there's no, I don't know who determined the 2-second rule, but I don't know, it should have never stuck. So we will skip all that. All right, in the control of external bleeding, they're not really talking, well, I say that they're not really talking about it because here's the tourniquet. External hemorrhage, life-threatening bleeds, I want you guys to kind of put before your ABCs. So if you were to take a PHTLS class, which stands for Pre-Hospital Trauma Life Support, and you don't have to take it because we actually put the curriculum in this course, so you're going to get it on the way. It's just better additional trauma training. You're going to come out ahead of your peers from other programs. But they don't just teach ABC, they teach XABC, the X being external hemorrhage. So when you show up to your patient, you're coming out of your scene size up and into your primary as you're walking up to your patient, that general impression portion in trauma, you're just look at your patient. Do you see blood shooting across the room? Do you see a giant puddle of blood on the ground? That kind of thing. That's the point where you take care of where did that come from? Because, I mean, think about how long it took to get through A and B, checking their pulse, checking their AVPU and all that. If they've got an arterial bleed or some massive hole in their body that needs to be fixed, by the time you get to circulation, they may not have any blood left to circulate. So we want to make sure that we plug any major holes early. All right. So at this level, the bleeding is not really what you're concerned about. The bleeding should have already been addressed. But for sake of the slides, the way that we control bleeding, you're going to start with direct pressure. So you'll grab a big stack of 4x4s, squeeze their arm, put some pressure on it. Hopefully that secures it. You can wrap it so that bandage stays in place, and hopefully that controls the bleed. If it's a massive, massive bleed, like let's say they chopped off their foot, or they, you know, something yanked their arm off, or yanked it off at the elbow, for example, and they're bleeding out profusely, direct pressure is probably not going to fix that. So we're going to go straight to the tourniquet. They used to teach elevation, which is, it's even worse than the cap refill. You have a blood pressure, right? Your blood pressure exists to defy gravity. So what does anything about raising your extremity going to do? You're just going to shoot your blood straight up. That's all that's going to do. So they finally decided, that's not how physics works. We're gonna stop doing that. So they took that out. It's just direct pressure and tourniquet now. You can still do the pressure point. Problem with that is if that's not, if the pressure point you can reach is not the artery that's having the problem, it's a waste of time. So if they're bleeding out the radial artery, you can put pressure on the radial artery and stop the blood. But if they're bleeding out a deeper artery that you can't find, then screw that. Just put the tourniquet on them. All right. So once you get to the end of your ABCs, you're at the end of your primary assessment. This is the point where you're going to determine the priority of patient care and transport. It's either a high priority or a low priority. There's a couple of things that will make a patient a high priority. Unresponsive is a big one. If they look like they're about to die, they probably are. Any problem with the ABCs that you have to address. If they have difficulty breathing, they're a high priority. If they had a bad pulse, if they look like cool, clammy skin, and you're like, I don't know what's going on, but they don't look good, those are high priorities for transport. Altered level of consciousness. They might be alert, talking to you, but something's wrong with the head, right? They're talking out their mind. They don't know where they are. They're trying to go to the bathroom in the produce section of the rest of the grocery store because they don't realize that that's where they're at. That kind of thing. They're going to be a high priority. They actually took Trendelenburg out. So yeah, when we get to the shock chapter, we're gonna go into the treatment of shock. But they got rid of it. And I know why. And I'm kind of glad they did it. So now when you treat for shock, it is just cover the patient and loosen restrictive clothing. Think about what Trendelenburg did. That's for you guys that have never heard of that. That's where you position the patient almost head down, where their legs are raised, and the goal is to have all the blood kind of pool around the core, the brain, where it matters, right? We don't care about if blood flow makes it to our feet, so we're going to let gravity work for us. And in the cases of poor blood pressure, that's not a bad idea. But here's the thing, here's where people were making the problem. If you showed up to a scene and you had a patient with elevated pulse, elevated respirations, out of whack blood pressure, and it's a trauma call, okay? They may have lost some blood. They may have hit their head. How do you know which injury is causing the vital signs? Is it shock or is it a traumatic brain injury? If it's a TBI and we invert our patient, we are speeding up the process of that intracranial pressure, which I know that I'm getting way out of the chapter here. We're going to get to that. But ICP, intracranial pressure, has to stay at a certain range. If we invert our patient and we increase that, especially if they're having a head injury and they're already fighting that high pressure, we've made a bad situation worse. The problem is that there's a different set of vitals, but they are very similar. You have to really know your triads to know the difference between shock and a head injury by the vitals. And if you miss the one difference, you'll treat it wrong. We bang shock into you guys so much that it makes it to where you miss the TBIs. So they're kind of getting around. They're starting to talk more about TBIs. And I'm just waiting on that to be the overkill, and then we're going to start mistreating shock. Eventually we'll find the middle ground to it, but that's where your continuing education and your experience comes in. I don't expect you to know the difference in school. You're going to come out, you're going to deal with it in the field, and you're going to be like, I see the difference, and then from there you'll be fine. The problem is Until you see that, you run the risk of treating your patients wrong if we flip them upside down or even just invert them a little bit, like the Trendelenburg position. So that's why they removed it. Who knows? Give it 5 years, you may see it come back. All right, some more issues for high priority. Uncontrolled bleeding, responsive, but unable to follow commands again. So they may be walking around and acknowledging that you're there, but they're not. It's like the lights are on, but nobody's home. Severe chest pain, all right, could be cardiac in nature. And without a 12 lead or a paramedic there to kind of get some real definitive looks, we really don't know. So they're going to be a high priority. Pale skin or other signs of poor perfusion. Poor perfusion, hypoperfusion means shock. If they're in shock of any kind of reason, and there's a bunch, they're a high priority for transport. Complicated childbirth, high priority. I don't know about you. I don't personally like making a habit of delivering babies in the field, especially when there's problems. And then severe pain in any area of the body. If they're at a 10 out of 10 and you can tell that they're not just trying to pull a fast one, they are really, like, you can see it, their responses are 10 out of 10, they're hurting, they're a high priority. No, it's gross. It's a mess. It looks like the mom exploded in the back of the ambulance by the time it's all done. Oh, don't worry, you will. You will. All right. So the golden hour and the platinum 10. This is the time frames that we love to try to hit because it's the best outcome from our patients. But depending on your location in relation to the scene, depending on how long it took somebody to call 911 in the first place, that's 3 died. Oh, that sucks. That's not a good win-loss record. Jesus Christ. I haven't had that. I've been fortunate. I haven't had any deaths. So the golden hour and the platinum 10, it's almost impossible to hit these, but we try. All right. So golden hour means from the time of the accident to the time they get definitive care, which definitive care means the hospital. We are not definitive care. We want it to be within an hour. Our goal is to get them packaged for transport within 10 minutes. And that actually is easier to do than it sounds because that clock doesn't start until you arrive. So the minute, for example, when we're doing your scenarios, the minute you say BSI scene safety, that starts that 10-minute timer. You have 10 minutes from BSI scene safety to determine that your patient's high priority for transport and you need to get him in the truck and go. It's actually a critical fail if you don't. Now, that sounds scary, but if you think about, we've already passed the point in our discussion tonight of where you're going to make that decision. You get through your scene size up, you get through your primary, it's right there. It's the last step. My patient is a high priority for transport. By the time we get done with boot camp and you've had some reps with your assessments, you're going to be to that point in like a minute and a half, 2 minutes. So you're going to find that the platinum 10, if you don't hit it, it's not there that something's wrong, but there is definitely a break in either we didn't teach something properly or there's some extenuating circumstance, say, Rob decided to give a teaching moment while the clock was running or something, and it just rambled your ear off. But normally you'll hit it in no time. Some patients will benefit from immediate transport. Others can be better served on the scene, depending on what you need to do. You may not need to do it all in the truck. In fact, if you think about it from a paramedic standpoint, if you've got a patient that's a hard stick for an IV, do you want to do that while you're bouncing down the road, or do you want to hopefully have at least 30 seconds on the scene to stick the needle through while you're able to sit still on solid ground? So hopefully, on scene, hopefully you've got a minute to do that. And paramedics are taught, if that's their case, they can structure their assessment in a way that they bump that to the front and then they get on the road. Or go ahead and get on the road, get going down the road, and when you get to the point of sticking them, just tell the driver to stop driving the ambulance for a second. Pull over, let you stick the patient, and then continue on. All right, from here on is your secondary assessment as I claim it. So you have your history taking, you have your vital signs, and you have your, if it's trauma, you have your head to toe. In fact, you know what? I'm going to show y'all. Give me a second. Let's see here. I'm going to switch gears. I'm going to show you your trauma assessment. So this will make a little bit more sense. All right, so here's the assessment as written by the registry, and I will show you why I hate it. This is what your assessor, your evaluator is going to see when you get to the end of this course and you have to do your skills. So you'll sign the top. When you get to this portion, as you can see, you have your takes or verbalizes appropriate PPE precautions, and then you have your 5 items for seeing size up. I always clump the PPE precautions in there with it so you can count to 6 rather than 1 and then 5. It just, put it together. So BSI, seeing safety. MOI, NOI, how many patients do I have? Do I need any additional assistance? And consider C-spine. Always consider C-spine, even if it's a medical. All right, doesn't mean you're going to put a collar on them, but you just want to keep that in mind. You want to keep in mind, was there any trauma involved in this? All right, then you go into your primary assessment. That is your general impression, level of consciousness, because at that point you're going to determine whether you're going to continue this or if you're going to go into CPR. If they are unresponsive, check the pulse. At that point, if you have no pulse, this scenario gets put on hold and you actually switch over to your cardiac arrest scenario, or assessment rather, and you run that. Assuming you get a pulse back, you'll come back to this, to that point, and then you will continue on down your assessment. So you'll do your ABCs, and as you can see, it tells you what within each one you need to do. This part of the assessment I agree with. I like it. You need to get your scene size up done first, then your primary. They must be done in that order, and you cannot leave the primary and do something else until you've completed it. You can't jump out of the primary and go into your secondary and then go back to your primary. That's a critical fail. After that, though, if you look down here, history taking, secondary assessment, and your vitals. That to me, I always clump that as secondary assessment. It's just easier for me to say it that way. And these are not supposed to be done in this order. It's just that the whole thing is in a list, so they had to put it in a list. I think it would be better if they wrote these in a flow chart, but I think they're just thinking for space. So once you get done with your primary, the next 3 steps are up to you. They're up to you based on what your patient is presenting with. If it's trauma and you're like, holy crap, you done effed up, AA Ron, you need to go. We're going to get you in the truck and go. But before you roll them, before you start manipulating their body and trying to put them on a board to get them in the truck, you want to know what their injuries are, right? So I'm not going to start with history taking. I'm going to start with what this thing calls a secondary assessment, which is a quick head to toe. You're going to check the head, the neck, chest, abdomen, lower extremities, upper extremities, the back. At that point, you slap the board on them and you get them in the truck. And when we get to trauma, we're going to go real in depth on what you're looking for and everything. But the whole point is not to fix anything in their head to toe. It's just to get a good idea of what their injuries are. So you know if they broke their left hip, we don't want to roll them over to that side, for example, right? Because then we're going to make a bad situation worse. So I would put that one first. Then you have your history taking and your vital signs. History taking is sample. And if they're awake and want to tell you about their pain, then you have OPQRST as well. You can do that, or you can do your vitals. The important thing is you get them all done. It doesn't matter what order you do it in. So don't get hung up on the fact that this is in a list. Okay, I don't want you to think that history has to come after the primary. It doesn't. Once you've completed the 3 parts of your secondary, all you have left is your reassessment. If they're stable, it's every 15 minutes. If they're unstable, it's every 5. And the easiest way to think about that is if they're unstable, they could crash and die on you, right? You don't want to wait 15 minutes before finding out that that's what happened. So if they're unstable, they get a shorter time period. You're going to get more reassessments, and you don't have to wait 5 minutes. If they're really bad off, then do it every 2 minutes if you've got time for it. You don't want to spend all day just redoing vital signs. You still want to get the rest of your assessment done. But if you don't feel comfortable waiting 5 minutes, then don't wait 5 minutes. The last thing that I want to point out on this is this critical criteria here at the end. These are the things that if you do this, any one of these, you fail immediately. All right. They won't even bother letting you finish the assessment. They will just stop you right there and say, I'm sorry, please step outside and we'll be with you in a minute. Failure to initiate or call for transport within the 10 minutes. That's your platinum 10 we just talked about. Failure to take or verbalize appropriate PPE precautions. That is step 1. If you skip that, you fail. So if you walk in the room and I give you dispatch information and you're like, okay, I'm going to check his airway. Nope, you failed. Make sure you do your scene size up in its entirety, starting with PPE precautions. Failure to determine scene safety. If you walk in the room and say BSI scene safety, you have satisfied both of those immediately, right out the gate. Failure to assess and provide spinal protection when indicated. So at the end of your scene size up, when you say I'm going to consider C-spine, you have satisfied that because you've made the assessment. Now, if they need it and you don't provide it, your evaluator is kind of stuck in between a rock and a hard place because technically you said you were considering it. But if you don't give it, that is failure to provide a necessary treatment or intervention. And I believe we'll get to that in a second. I think it's down here. Depending on the evaluator, they may be like, well, he assessed or he considered, so I'll take it. And then you may just get that evaluator's like, but he didn't say it or he didn't put it on there, so I'm going to fail him. Failure to voice and ultimately provide high concentration oxygen. You should give every patient oxygen, not necessarily 15 liters, but you should, all the patients we give you are going to need some level of oxygen. So when we get to the airway chapter and we start talking about how you're going to deliver it, you're going to do that somewhere in here. Failure to provide adequate ventilation or at least assess. So if you do the B in ABC, you've satisfied that. Failure to provide or appropriately manage problems associated with the ABC, hemorrhage or shock. Failure to differentiate patients' needs for immediate transport versus continued assessment at the scenes. When you get to the end of your primary and you say, my patient's a high priority for transport, I'm going to put him in the truck and go. That satisfies that one. Performs other assessment before assessing or treating threats to the A, B, or C. So again, you have to complete your primary before you go any further. If you are still in your, let's say you get to B, you find out your patient's breathing, and then you jump to getting a blood pressure or asking sample history. That's an automatic fail. You have to complete A, B, and C before you move on. Failure to manage the patient as a competent EMT. If you show up and you just flat out do not know what you're doing, you have that. Exhibits unacceptable affect. That is like if I told you that a patient was hurting, pain 10 out of 10, and it's in a way that a position change would fix, but you're like, no, you can't get in that position. I need you to lay a certain way, or I need to do a certain thing, and you're not paying attention to the needs of your patient because pain is a big thing, right? Pain spikes your vitals. So we want to try to minimize that. We can't give morphine. That's not our level, but we can do positional changes. We can do bone stabilization. A lot of times stuff like that will satisfy that particular thing. Doesn't get rid of the pain, just makes it better. And if it's something that you need a paramedic for, you can say, okay, well, if his pain's 10 out of 10, then I can't fix it. I'm going to call a paramedic to come out and give some analgesics. There you go. You have taken your patient's pain and comfort into account. And then the last thing is uses or orders a dangerous or inappropriate intervention. If you try to give somebody nitro because they are having trouble breathing, that's a fail. All right, because nitro doesn't go to trouble breathing. In fact, nitro will make most breathing problems worse. So, and again, you'll learn all about that. But my point being is that you want to make sure that the interventions you do meet the call that you're on. But that's your assessment. Your medical assessment is almost identical. The only difference is your secondary assessment is not a head to toe physical check. Your secondary assessment is specific to the body system that is having the problem. You get a call for trouble breathing, you need to focus your secondary assessment on their respiratory system. If it's a call for chest pain, you need to focus on cardiac, that kind of thing. It's actually easier because you don't have all these different things to check. But like I said, if you look at it from the scene size up has to be done first, then the primary, and then the secondary is everything else except reassessment. And you can pick and choose what order you want to do them in. As long as you get them done, that's all that matters. All right. And then keep in mind, like I said, for trauma, the head to toe, I want you guys to do that before you try to move your patient, because it tells you what injuries you need to be aware of while moving your patient. So that should be the first thing. Then you can get your vitals or your second or your history and the rest of the stuff on here. All right. I know I ran a little bit long on that one. Take another 10-minute break. Be back. What is it? 18? Yeah. Be back at 8:18 and we'll continue on. One of these days, I'm going to figure out what that tone is. Okay, so let's get back to it. Because I have already shown you your assessment, we are going to start flying through slides from here on. No, I think that tone is somebody logging out, but I really don't see the numbers dipping that much. So I wonder if it's, oh, no, now they're starting to drop. Dropping like flies. That's it. I've lost them. The class is running along. All right, anyway, we're going to start flying through slides now because I just need to talk about a couple of things that we didn't touch when I brought up the actual form. But other than that, it's going to go pretty quick. We're going to hit this, like I said, every single chapter of Module 3 and every single chapter of Module 4. We're going to be talking about how it fits into this. So if you're not a master of the patient assessment by the end of tonight, think of it like anatomy. It's perfectly fine because you're going to keep revisiting it as we go. But anyway, talking about history taking, there's a couple of things that we're going to check for here. We have two mnemonics that I want you to remember. It's going to be sample and OPQRST. All right. The things to keep in mind when you ask questions is keep them open-ended. It says it for the chief complaint, but I want you to keep this in mind for all of your questions. You're not really going to say, is your pain sharp? Or does it feel like an elephant is sitting on your chest or something like that? Even though those are some kind of things that we would want to hear. If you start pointing your patients down answers like that, a lot of times they're going to be like, you know what? Yeah, it does kind of feel like that. And that may not be how they would have described it in their own words. And because of that, we can kind of get some bad information out of them. We're almost getting what we want to hear. And that's not necessarily what we want. We want to hear their words far. They may not describe it the same way, but we want to make sure that we're getting their take on it, especially when it's something that we can't see, like pain. Let me get to the right spot here. All right. If your patient's unresponsive and for whatever reason, okay, I'll answer her in a little bit. Sorry, I lost my train of thought. All right, so if your patient is unresponsive, obviously they're not going to be the ones to answer your questions, right? You can't ask an unconscious person what their allergies are. So you're going to get your sample history from a bystander, a family member, anybody who might know those answers. Now, a bystander is not going to have a whole lot of those answers, especially if it's a stranger, but they can give you information, particularly on, like, what happened? Who held his beer? Why did you? Who didn't think that was a bad idea? That kind of thing. Medical alert jewelry is good. They have your smartphones now have where you can put in like if you're diabetic, if you have a certain disease that a EMT or a paramedic might need to know about for your treatments if you're unconscious, you can put that stuff in your phone now and it can be accessed from your lock screen. So you don't have to give somebody access to your phone. You can still keep that privacy, but they can actually access that and go, oh, this guy's a diabetic and he's unconscious. Okay, I might need to keep that in mind. Or he's got leukemia. That's something that we might want to know, right? Especially, or if it's HIV or hepatitis or stuff. I know it sucks. You don't really want to put that kind of thing out there. But some things, just for safety reasons, should know. And as long as you are not hurt and unconscious, incapacitated on the side of the road, nobody's going to dig in your phone and find that. That is really just there for if, Medic 103 is riding down the street, sees an unconscious person on the side of the road, and nobody knows anything. So they grab his phone, look at his lock screen, hit the medical ID icon, and they get some information to kind of give them at least a little bit of a route to start on as to what might be going on. All right. So OPQRST, did I just straight up pass sample? Oh, that's next. Okay, that gets its own. So OPQRST, the redheaded stepchild here that doesn't get its own heading, is how we were going to assess pain of an unknown origin. So the way that I described this, if I break my hand, all right, let's say I stuck it in a wood chipper because I was an idiot and I chopped off my hand and ow, that hurts. You don't really have to ask me what I was doing when it happened or if something makes it better or worse. Those it's pretty apparent that the problem is that I was dumb enough to put my hand in a wood chipper and now I don't have a hand anymore, something of that sort. The OPQRST questions is mostly for questions like chest pain or stomach pain, where we can't see it. We can't really see why they have it. We don't know. Like if you got a call for chest pain, how would you know if your patient was having a heart attack or heartburn or gas or something of that sort? These are the questions that you would ask to kind of narrow it down. So onset. All right, onset is what were you doing when it happened? What were you doing when the onset of this issue started? Provocation is, does anything make it better or worse? So for example, if it's a chest pain, does lying down make it worse? Does sitting up make it better? If it does, now I'm starting to think more like heartburn, a little bit less like heart attack. Heart attack, your patient position doesn't adjust, doesn't change anything. The heart's still having a problem. So the pain's gonna be the same. Quality, this is probably the biggest open-ended question you could ask, all right? Because the question is essentially, describe this pain to me, okay? So an example of that, and I'm going to get a little bit into the weeds on this one, but it'll make sense, and I actually want you guys to keep this in mind anyway. So let's switch gears to stomach pain. If I want you to describe the pain to me, something that I would expect to hear would be, it hurts right there. And they can like point at it and say, it hurts right here. Doesn't hurt 2 inches away, doesn't, it is literally this one spot. As opposed to, it's just this whole side, this whole section right here hurts. It's dull, it's diffuse. And dull and diffuse doesn't mean mild. It can still be severe pain, but it's just kind of spread out. The difference between those two, if it's spread out, it's most likely an organ. All right, could be the appendix, could be the spleen, the gallbladder, the liver, any of that. The reason being is because your internal organs aren't really, they're not meant to be able to be touched, right? So they really don't need that many pain receptors. They really don't need that many receptors that can distinguish pain, pressure, that kind of thing. So if you have a problem with an organ, if it starts to swell or get inflamed, the nearest pain receptor might be further away from where that injury is, which is going to make the pain feel like it's coming from further out. So that pain is going to be diffuse. It's going to be kind of spread out. If your pain is kind of taking up an entire quadrant of your core, or even more, like say 2 quadrants, probably an organ. If your pain is really sharp and in a certain spot and it hurts, like you can, like I said, you can put your finger on it and say it hurts right there. And even, for instance, my finger is too big to specify exactly where this pain is because the pain is in such a small spot. That's more of a muscle, a visceral lining, something of that sort, because your musculature is very vascular, it's very neurodense. There's a ton of pain receptors because part of your muscle's function is to detect things just like your skin is. So if it hurts, the pain receptors are right on top of the problem. And so the pain's going to be very pinpointed. That's a good way to determine just right out the gate kind of what you're looking at. And it makes sense too if you think about it in terms of a heart attack. If it's the heart, if it's actually a heart attack, you don't ever hear that it hurts right there. It's usually the pain is kind of in the center of my chest. It's just right here, and they'll open-handed touch their chest because it's all that area. The whole pain radiating down to the left arm is because the heart typically points to the left side of the body. So when something's going on, the pain receptor might be somewhere else off the organ that's picking up the problem. It's a deferred pain, and that actually is what we're going to get to here in a second. So the next one is radiation. Does the pain travel anywhere? If it's a heart problem and they're male, some females, but mostly males, the pain's going to kind of go off down their left arm. Like I said, the heart sits in the center of the chest, but it angles to the left. So the pain's going to kind of shoot that direction. One tenth of 1% of the human population, everything is reversed. You might be the lottery winner that comes across a person whose heart angles to the right, but I mean, that's very rare. Severity is your pain scale. All right, so that's 0 to 10, 0 being you don't have any pain, 10 being you shot yourself in the face with a 12 gauge. And then timing or time is it, how long has it been going on? Or you can look at it as, does it happen, does it come and go in spurts, like say labor contractions? These kinds of, anything to do with timing would be in that question. And so all of these questions are designed to help you kind of pinpoint down what it is you're looking for. And it's not just about what they tell you they have, it's also about what they don't tell you they have. Like, for example, just for sake of time, I'll say it. So nausea and vomiting always go together, right? Well, at least almost always. You always hear them together. I got a patient complaining of nausea and vomiting, blah, blah, blah. Usually when they go together, that's because it's a GI problem. The GI tract is messing up, so you're nauseous. And then if it's bad enough, the GI tract decides to try to purge it, and so you throw up. What do you think it might be if it was, how do I word this? Can you ever think of any kind of issue where you might have a patient with no nausea, but projectile vomiting, where it just launches? They could be mid-sentence and just, there it goes. They just shot vomit across the room with no warning. We have gotten nowhere near this chapter yet, but well, acid reflux can kind of, that'll give you some nausea because it's GI related. Head injuries. Somebody has a brain bleed, it's putting pressure on the brain. When the vital signs start to mess up from something other than the GI, the nausea isn't there. So intracranial pressure increase, something where they got hit in the head, they might be fine, at least, well, I'll say that, they're not fine, but you'll be looking at symptoms of one thing, and then they'll just puke everywhere. Like it just comes out of nowhere. There's no, oh God, I think I'm gonna puke. It doesn't happen. It's not like that. They just projectile vomit. It just launches with no warning. That's a sign of a head injury, and that's a pertinent negative. In other words, something that normally would be accompanied with one symptom is just not there. Yes, concussion is a great example of that, especially if it's bad enough. So identify that. If your patient says that if you walk in, the patient's been throwing up, and you say, "Oh, I see, we got some nausea and vomiting," and your patient looks at you and goes, "No, I'm not really nauseous," and then, okay, well, I'm gonna write that down because that means something. Your other set of questions for your history is your sample. Sample is more about your patient's actual history, not about a pain. So if a patient doesn't have any pain, there's really no place for OPQ-RST. So I don't want you to feel like you got to ask those questions on every single scenario you get or every single call you run as an EMT. It really has a purpose, and that purpose is pain of an unknown origin, where you're trying to narrow down what it is. Sample, though, everybody gets these questions. This is the history that you're going to do no matter what. Pain, no pain, whatever. Signs and symptoms. All right. Signs are things you can see, things you can measure. Symptoms are things that they have to tell you. They're completely subjective. So a headache is a symptom. Sweating, diaphoresis, that's a sign. All right. So a sign of a heart attack would be sweating, cool, clammy skin. Those would be signs. Symptoms of a heart attack would be vitals being out of whack, or pain radiating in the left arm, epigastric pain if it's a female. Those would be your symptoms. So that's the difference between the two. And pay attention in your tests, because I specifically remember, and granted this is a long time ago, they've probably thrown this question out by now, but I remember a question that said, which of the following is a sign of a heart attack? And there was nothing about the word sign that drew my attention to it. They didn't bold it, they didn't underline it, nothing. And they gave me 4 options, and all 4 of them had to do with a heart attack, but only one was a sign. The other 3 were symptoms. So You know, that's how the registry tricks you. It's not that there's two right answers. It's that you're just not seeing the difference between the right one and the wrong one. It is a difference. There is a difference. Allergies, not just drug allergies. There are certain food allergies that we need to know about, like iodine, because if they have an iodine allergy, they can't get atropine, which is a paramedic's drug, but something you might want to be able to tell that paramedic so he doesn't try to give them something like that and then them go into cardiac arrest on him or have some massive anaphylactic allergic reaction. Medications, you want to know what they take. You also want to know if they're compliant with it. So if a patient tells you that they're on a blood pressure med, all right, it's not good enough to know that they're prescribed it. You want to know if they took it. And if they did take it, how much did they take? Did they take too much, too little, what they were prescribed, that kind of thing? Because you're going to run into patients that, like diabetics, for example. Type 1 diabetics have to take insulin shots. A lot of times, the elderly will take an insulin shot and then either forget to eat, or they'll eat and then forget that they already took the insulin shot and take another shot, and they crash their blood pressure. It just happens. So you want to get all the information you can. If you're responding to elderly patients and they've got a shoebox full of meds, just grab the box and bring it with you. It's the easiest thing to do. Pertinent past medical history. Notice that the highlighted P is on pertinent. All right. You take insulin shots for type 2? That's interesting. I wonder why I know that metformin, like a lot of times they'll give you a pill. Usually the insulin shots are type 1 because the body's not creating insulin. So you have to inject it yourself. Type 2, the insulin's there, it's just not working. That's interesting. Pertinent medical history. You want to make sure that the history they tell you is pertinent to the situation. You don't need to know that they broke their ankle when they were 6 years old. Now, if they broke their ankle 3 weeks ago, that might matter, especially if they had surgery or they had some heavy bleeding involved with it. If they had a surgery within the last 3 weeks or so, that's important because you run the risk of a clot or a issue with their healing, that sort of thing. So those are the things you want to know about. Last oral intake, get that. You don't really have to know what they ate unless you're dealing with an allergy, but it's good to know when they ate. And then the events leading up to the injury or the illness, that's just one of those fill in the blanks. Like, all right, so what happened? And a lot of times you'll actually get the E before you'll get the answer to E before you even get to sample. So if you already know the information, you don't have to ask it again. You're gonna use critical thinking. We do have a lot of protocols, a lot of like step-by-step things. I mean, the whole point of this chapter is a step-by-step process, but I don't want you to become robotic. All right, this is a guide, not a policy. It's only a policy in class. If you need to bounce around, especially for heart patients, because like for example, we need to give nitro for a heart patient. Some of the stuff we need to know to give that nitro, we're not going to get until the end of our assessment. And if you want to hurry up and give it, you might have to, once you get done with the primary, you might have to go out and nitpick the things you need to give the nitro. Like, do you have any allergies? Did you take any erectile dysfunction pills? That's the M in sample. What's your blood pressure? So now you jump from sample to vitals to get the information you need to be able to give a nitro. Don't forget where you left off. All right. Eventually you have to go back and get the rest, but you don't always have to do it just sample, just OPQ-RST, just vitals. I will ask you to do that while you're learning your assessments, but when you get out into the real world, that is another difference. You can hop around. That's okay. Okay. Let me get caught up here. You do need to get history on sensitive topics, like the slide is saying. My Siri keeps going off. The big thing, stop, not talking to you, Cyrus. The big thing you want to keep in mind is that sometimes patients may not want to answer honestly. All right. So for example, where we're doing CPR, where we're doing the boot camp here, they had a guy fall out the other week. They hit him with Narcan, and he woke up. Imagine that. So then they asked him if he had any, if he was taking any opioids, and no, I don't do that. Okay, but the Narcan woke him up. So, either A, we found a really great use for a medication, or he lied. If you ask a teenage girl in front of her parents if she is sexually active, I can pretty much put money down on what she's going to tell you. So, keep that in mind when you're doing things. Alcohol and drugs, a lot of people actually have a level of shame to any vices, any habits like addictions that they may have. It's very important that we don't judge them. That's not our role. They need to know we're not the cops. If they're doing something illegal, that's not our job to arrest them. It's not our job to say anything. Patient confidentiality stops us from doing that. We're there to help. So make sure they know that you can reassess them or reassure them. If you're dealing with the possibly pregnant teenager, get her away from her parents. I say that having a 16-year-old, I don't expect that. In fact, okay, first of all, I shouldn't have to have another ambulance come out to my house. But if they came out for something for my daughter, when they start asking the questions, I'm going to bounce out the room because I want her to be honest with them. And I don't want my presence to mess with her answers. So same thing from the EMT side, doing the questioning, you may need to be like, all right, come on, we're going to get in the ambulance and head to the hospital. And when you get in the ambulance and you close the door, then you can ask these questions where they're away from the parent. They're going to give you honest answers, that kind of thing. Physical abuse and violence, a lot of times they don't like to admit that they're being beaten because they don't want either A, they don't want to get beaten worse, or B, there's a little bit of Stockholm syndrome involved in it where, he only hits me because he loves me, or it's my fault. If I didn't do this, he wouldn't have hit me, that kind of thing. So a lot of times they may not want to be honest with you there either. And then this is a slide about sexual history, like I was talking about with the pregnant teenager scenarios. All right, some special challenges. Silence. So if they're just not wanting to talk to you, just don't get the question, or don't force it. They'll answer when they can, when they want to. They may not say a word to you, and then they're going to sing like a canary at the ER. That may happen. All right. They just may not trust you, or they may know that you have them for such a little amount of time. They don't want to bother telling you because they're going to have to repeat everything at the ER. Some people just know that every new practitioner they meet is going to ask them the same questions. So sometimes you'll get that patient that they're like, yeah, whatever, I'm not answering you. Some other symptoms, depression can be an issue. If they're overly talkative, that can be an issue. I've actually had students who did this. It was like a nervous tic. Every time they felt like they were on the spot, they would just start talking. Just absolutely nothing to do with the class. Just word. I didn't mind. Like I love when y'all talk to me, even if it's unrelated. As long as you can kind of loosely tie it to the class, and fantastic. I'd rather that than it be completely one-sided. Which lectures, especially in this environment online, is very much one-sided. I can't see you. I can't even if you got your cameras on, I can't see you. All I see is my slides. But I know you can't see me. It takes a lot away. It takes all the nonverbals away. If I see somebody's eyes gloss over in the classroom because you're just not getting it, I can go back and fix, explain it a different way, stuff like that. I don't have that in this environment. So I rely on you guys being two-way street. Talk to me, text, in the chat room, whatever you want to do. And it could be the same thing on a scene. Your patient may not want to say jack shit to you. Your patient may not want to shut up. It's just, and I say that in the way that like what they're saying won't have anything to do with what you're trying to do to help them. they'll be talking about their dog, they'll be talking about the neighbor and what they caught their neighbor doing, and all this stuff. And a lot of times that is a deflection from what's going on. They know they need help and they need to go to the ER or something like that. But if it's an embarrassing issue, say that they were doing something in the bedroom and it didn't work out in their favor, you might get this where they're just saying if they don't stop talking, you can't ask those sensitive questions. So sometimes that's, in fact, the last time I had a patient that was doing that, that's what it was, and I knew it, and I was like, that's fine. I don't really need to know that information, so I'm not going to ask it. I didn't see any real signs of trauma. So we're supposed to ease their mind at all when they are rambling and possibly lead to the question again. Yeah, if you can find an opportunity to insert that, then go right ahead. Just be careful with how you do it. All right. If you're too direct, it'll still shut them down. But you can just let them know. You don't have to say, I know you're talking to avoid something. You can be like, hey, I'm just trying to help you. I don't need to know a lot of details. There's a couple things I want to check to make sure that you're not going to, that I can give you the right treatment. And if I ask a question you absolutely just don't want to answer, then just don't answer, that kind of thing. And then just go from there. You may not have that opportunity. They may just one giant breath and then not stop till you get to the ER. All right, give me a second because I got lost in my lesson plan versus the slides. Okay, here we are. So I already talked about that when we talked about intoxication, crying. We mentioned depression. Just be a good listener for that one. There's nothing you can do to fix depression. That's either going to be a psychologist or a psychiatrist. EMS, our biggest goal is just kind of really be that patient advocate. Let them talk if they want to talk. If they're depressed to the point where they won't look at you, they just kind of sadly look away. Let them. I'm not saying be mean. I'm not saying ignore them, but you don't have to force it. Is what I'm getting at there. If they're confused, such as like hypoxia, stroke, diabetes, a lot of times if they have a condition that's making their brain not function properly, the behavior of the patient may not match what you're dealing with on the scene. So keep that in mind. If that's happening, if you can't trust their answers, then don't trust their answers. Treat it like they're unresponsive. You can take care of everything else. If they give you answers and you're just not sure, you can write down what they said and then just put like a little asterisk by it or something so that you can say, patient gave me this information. It may not be right. Cultural challenges. Some people don't understand medical language and they get kind of put off when you use it. They think you're trying to be better than them. So be careful about that. When you're talking to another medical professional, I want you guys to be knowledgeable of your medical terms. When you're talking to the general public and patients, plain English. All right. Don't say tachycardic to a 6-year-old. They're not going to come out. You say your heart beats really fast. Same thing with an adult. They may not know what tachycardia means. They may not know what hypoxia means, that kind of thing. So when you're talking to them, use regular language. When you're talking to the doc, that can be different, but not your patients. Some cultural challenges, some Muslim families, if you are a male and the patient is a female, they would rather the patient die than you take care of them. Not all, but a lot of your traditional ones, you just can't touch her. You're defiling her if you touch her. So that sucks. If that's the case, then get a female EMT out there if you don't already have a female partner. A lot of ambulance companies try to mix genders on an individual truck so that that's taken care of. It may not even be a cultural thing from a religion standpoint. It could just be, dad doesn't want a male EMT looking at his daughter. So sometimes you have to kind of deal with that. Language barriers, depending on where you live in the country, you may have non-English speaking people. There are apps out there. You've got Google Translate. I actually had for a long time before I actually learned Spanish, I had an app that was all my medical questions, kind of call I needed to go on, and I didn't have to say anything. All I had to do was click the question and let it say it for me. And all the questions were easy answers. So the question, like if I clicked on it, it gave me a small list of what possible answers they might say. And so I would just look at if what they said sounded like what I was looking at, the English translation was next to it. That was before Google Translate kind of took over the world with that. But it was a pretty cool little app. It worked for Spanish. I liked it, which is good because Laurel, Mississippi, not even near a border town. Laurel, Mississippi had a pretty big accident happen on 16th Avenue, which is one of the main streets in the town. And it was a fairly small car, but it had like 8 Spanish only speaking Mexicans inside of it. And they were all in various levels of injury. So there was a whole lot of ayúdame being screamed out. None of them spoke English. None of them had an ID on them or anything like that. And that was a tricky call because I couldn't get any information and I didn't understand what they were saying. And when we got into the ER, the hospital staff didn't know what they were saying, and they really couldn't enter any information in because, like I said, none of them had any IDs. So I know that that's a big political topic these days. As far as EMS goes, don't let your political views, which one way or the other, cloud your judgment on taking care of your patient. They're human. It's really all that matters. All right. Hearing problems. I think we talked about it in lifespan development. A lot of times when you lose hearing, it's more that you're losing hearing from a certain pitch, a certain like a range of frequency. So you don't necessarily have to shout at people. You can change the pitch of your voice and they may hear you better. If they are just flat out deaf, or if you just can't be heard, use a pencil and paper. You can use voice to text on your phone. Any of those will be fine. Break that barrier somehow. Visual impairments can be difficult because they can't really see you, so you're going to have to be very verbal about what you're doing. Basically, I just tell students to think out loud. All right, I'm going to get your blood pressure. So I'm going to be putting this cuff on your left arm. It's going to get a little bit tight. If you've never had your blood pressure checked before, don't worry. It'll squeeze and then it'll stop. If it does hurt, let me know. I'll take it off. We'll try the other arm. Sometimes people might have an injury and that cuff could hurt them. So you just let them know, like, as I'm inflating this, if it actually does start to hurt, tell me and I'll stop, that kind of thing. All right, your secondary assessment. This is basically your head to toe. And I want you guys to do this before you ever move your patient. So this will be done on scene all the time. I don't want you to start trying to roll your patient when you don't know what injuries they have. So very quickly, then this is a quick process because you're not fixing anything when you're in this process. You're head to toe. You're looking for a certain set of injuries. Not going to get into that tonight because that's all for trauma. But I want you to remember it's a systematic approach, just like this whole assessment is a systematic approach. Usually when it's trauma, this is what I want you to do after your primary. All right, because you're going to want to move your patient. Figure out what the injuries are so that you know how to move your patient without making those injuries worse. You're going to check your head, face, neck, chest, abdomen, groin, hips, whatever side of the patient you're on. You're going to check that leg first. Then you're going to switch sides, come back up the other leg, check the arms, roll the patient to whichever side you feel they need to be rolled on based on their injuries. Check the back, the butt, make sure there's no bleeding from the rectum, that kind of thing. Before you roll them over, stick the board underneath them, roll them back onto the board, strap them down. Now they're ready to go. When you get them in the back of the truck, then you can start trying to fix those injuries you found. But pretty much at that point, it's just whatever they tell you, it's going to note it and move on. All right. I noted the fact that he has some distension in his stomach. Really can't do anything about that anyway. so I'm not going to waste time with it here. I noted the fact that he has a broken leg. Really can't do anything about it. I can, but I don't want to waste time doing anything about that while I'm sitting on the ground outside. So I'm going to get him in the back of the truck. Then I'm going to splint his leg while I'm going to the hospital, because we're trying to get them there in that 60 minutes or less golden hour. And that's pretty much all there is to the secondary assessment. That is just your quick head to toe look. If it's medical, then it's not so much going to be head to toe from a trauma standpoint. You're not poking the head of somebody who tells you that they've got chest pain, right? That part's different. You can do a quick once over and just be like, do I see any trauma? But you're not going to do a whole head to toe. What you're going to do is just that quick glance, and then you're going to focus your assessment on the body system that's affected. So again, if it's an asthma patient, we're going to focus on respiratory. If it's a cardiac patient, we're going to focus on the cardiac system. Diabetics get their endocrine system focused on. That's kind of what that is. And you're just going to do the checks that you would normally do. So when you assess for the trauma, it's inspect, palpate, and auscultate. So inspect means look, palpate is to touch, and you're really going to be touching around the abdomen because we're trying to feel for certain things like distension, tenderness, that kind of thing. And then auscultate is when you're going to listen. Mostly what you're going to listen to are going to be lung sounds, gastric sounds, so you might listen over their stomach, over their chest, their heart, their heart too, even though we really don't do much with that at the basic level. And then their lungs. Pretty much any hollow organ that could have some problems, we're going to listen and see if we can hear any problems. Using mnemonic DCAT BTLS, I will tell you this now, what it stands for, but you don't have to memorize it yet. This is going to be a mnemonic that you use when we get to the trauma module, but it's deformities, contusions, abrasions, punctures, burns, tenderness, lacerations, and swelling. These are all signs, right? Everything I just named are things that you can see. So if this were a real patient, you would just say, all right, I want to look at the chest. Do I see anything other than nice, warm pink skin? It's really easy to do DCAT BTLS in person. It's hard to do it in a scenario with a mannequin because I'm going to have to tell you what you see. That's just the downside of it. But when you get out to the field, DCAT BTLS is easy. You're just going to look and be like, it's a pretty gnarly deformity you got there. Or, damn, I'm pretty sure there was supposed to be skin there, but it looks like it all got scraped off, that kind of thing. It's pretty easy to find. It is a systematic approach. And then once you get into the truck and you're moving, now you're going to start to focus your assessment. You're going to base it on the chief complaint. And this is where you're going to start focusing in more about the problem. So those broken legs that you didn't deal with on the ground, that's where you're going to deal with it. It's basically just a second round of head to toe. You're going to look a little bit closer. You're going to pay more attention to the nitty gritties. You're going to start to fix the things that you saw. You may not get to this. If you're 5 minutes from the ER, you're probably not going to get a chance to do this. And that's okay. Hopefully you don't have time. That means that they got to the hospital that fast. But a lot of y'all that are in Mississippi and stuff like that, you might have a 30 or 45-minute ride to the hospital. So it could take you a while to get there. Other than that, I'm not really going to talk too much about the focused assessment or the actual systems, because we're going to get into this stuff when we get into the chapters for the systems. So we'll skip these. I want to get to the next part of the actual assessment, which I think will be, this all has their own chapters. Same with that. Vital signs. All right. So there's four main vital signs that we want to get. And then there's another one we want, depending on if our patient has an altered level of consciousness. The four main ones, you're going to have breathing rate and quality, right? So we want to know if they're breathing 16 times a minute, but we also want to know if it's good, shallow, labored, rapid, too deep, that kind of thing. We want to get their pulse, and this is another one that you get the number and a quality. So it's going to be pretty much the same thing, rapid, bounding, which means it is everyone's hitting like a jackhammer. Weak and thready, where you can barely tell that it's there. Those are the things that help describe the pulse, and they matter. You want to get your O2 sat, which, as you can see in the picture, anybody remember what our preferred range for O2 is?
96 to 99.
Close. Travis got it. 94 to 99. There we go. Not bad. 26, you're not wrong. I mean, you're in that range, but yeah, you can go as low as 94 and be okay. Just like any other vital, if we want you to know it's low, we're going to give you a number that is definitely low. I'm going to tell you that they have like a 90 or an 88 or something like that. If I told you they had a 94 or anywhere close to your range, I want you to know that it's normal. All right. So you don't have to worry about that. Like if I want you to think it's low, I'm going to give you a definitely low number. And then the fourth vital sign that we always get is blood pressure. Most of your vitals exist to maintain your blood pressure. If you remember that, then when we get to trauma, you're going to find that blood pressure is actually I'm sorry, when we get to trauma, you're going to find out why shock is the way it is and how when we compensate, why our vitals are doing what they're doing, and how you can tell if you're compensating for shock or if you're seeing vital changes based on a TBI, like I was mentioning before. So know that your pulse is to maintain your blood pressure. Your respirations tend to follow your pulse. So if your pulse climbs, your respirations are going to climb. You don't really see them get out of sync. And then if you need a fifth, if there's a altered level of consciousness, if they're unconscious, if they're just not right in the head, that kind of thing, something there's some confusion going on, we need to get a glucose because they could be having a diabetic emergency. They could just be hypoglycemic. It could be something else causing the glucose to get out of range, but the important thing is that we know the glucose is out of range. A lot of times that's why they're having their altered level of consciousness. It sounds like somebody's having a fight in the hotel hallway. I'm losing my thought because I have people out there yelling. Sorry. We can fix glucose as long as our patient's awake, and if they're not awake, then a paramedic can fix glucose. So if it's out of range, we want to try to fix that. A lot of times that will bring your patient back to at least a lucid state, even if that wasn't the actual problem. And then with that, we can get our history done that we couldn't get before because they were out of their head, that kind of thing. Glucose issues is also mistaken all the time. We'll talk more about this in the actual endocrine system chapter, but a lot of times it's mistaken for being drunk. So police have gotten a lot better about it, I'll say that. But they used to mistake hyperglycemic patients for being drunk. They would lock them up for the night where they put the drunk people and then come back the next morning and find them dead because they weren't drunk. They were having a diabetic emergency, but the symptoms looked so close that they just assumed they were drunk. And that's not always the case. The blood pressure that we use is non-invasive, so we get it from the cuff. There is an invasive way of getting blood pressure, but that typically only happens in the hospital, so we don't deal with that. You're going to use a sphygmomanometer. Yeah, I actually said that properly. Which is actually your blood pressure cuff. It inflates on the arm, cuts off circulation, and then as you're listening, as that gauge starts to drop down in value, when you start hearing a beat, that's your systolic pressure. When you no longer hear the heartbeat, that's your diastolic. So if it starts beating at 130 and you stop hearing it at 98, that's your blood pressure. That's how we say it. It's 130 over 98 or 120 over 80 or any of that sort of thing. All right, and then your reassessment, very quick and down and dirty. You're going to reassess everything you've done, every intervention, especially any interventions done in your primary. All right, because those were your life threats, right? So every time you reassess, if you had to put a tourniquet on, you're going to go back and make sure that tourniquet didn't get bumped or come loose or any of that. If you had to bag your patient because they weren't breathing on their own, every time you go to reassess, You can stop bagging, see if they breathe better on their own so that you don't have to keep bagging. Just be prepared. You're probably going to have to keep bagging. But you want to see, you want to make sure that the breath you're delivering are working. We're going to have a little class on the BVM at your boot camps because there's a lot to it. And I may talk about, we'll see. I may, if I do your Airway chapter, I'll talk about it then. Mike will probably talk about it. He's very thorough. But we're going to talk about it at boot camp as well. So if we do go over it in lecture, then great. I can toss the BVM to one of y'all and have you tell me, like, tell me about the BVM. What do you remember? That kind of thing. But anyway, when you're reassessing, it's every 5 minutes if they're critical, every 15 minutes if they're stable. Every scenario you get in class, you're going to be critical. So get used to saying just every 5 minutes. But in the real world, if somebody called 911 because they're just having uncontrolled vomiting and diarrhea because they ate some bad shrimp, that's not an unstable patient. They might need to go to the hospital because they're dehydrated, but they're not going to die from that. At least not unless they've been ignoring it for a long time. Their vitals could be every 15 minutes. Normally, though, a real 911 call where it could be a life threat, it's every 5 minutes. And then look for trends. Remember my little soapbox about the cap refill? And I'm nothing compared to the bitch fest that is Trevor on that. That's a trending tool. I really don't care if they're 2 seconds or less. I just want to know if that number is changing either for better or for worse as the call's going on. You're going to reassess your chief complaint. Why did they call you? They called you because their chest hurt. Okay. So as you're going through your assessment, you've given some interventions and everything. 5 minutes passes. Hey man, how's your chest feel? Is it feeling any better? Same? Is it getting worse? That kind of thing. Because you may have to adjust your treatment plan if what you did either wasn't enough or just wasn't the right plan. Hopefully it worked. Usually it will, but sometimes you're going to get patients that don't, and then you may wind up having to call ALS just because you realize your interventions were not enough. It may not be that you did anything wrong. It's just that what they need is beyond your scope. Recheck interventions. I already said that, and identify and treat any changes in the patient's condition. So if something new happened or if something repeated that you need to fix, then go ahead and fix that. And that's your reassessment. And that is it. Not bad for a chapter that large. Any questions on tonight? This is another, like I said, it's another one of those chapters that's not a mastery chapter. This is one that's supposed to be a giant overview because we're going to hit every chapter. We're going to kind of touch back on this from here to the end of the class. No questions? Okay. All right. So I'm going to give you your pen. Do me a favor. If y'all are having problems with doing your attendance form, I haven't really been getting a whole lot of. I'm supposed to get an email every time somebody does an attendance form, and I'm not getting them. I don't know if I'm having an email problem or if y'all aren't getting the attendance forms to work properly. So if you can't get it to work, you get email that signed attendance. Okay, y'all are getting them. Good. So then it must be my email. I'll have my web developer look at it. I just want to make sure because I haven't been seeing it. So y'all should be fine then. That's good to know. I'll get that fixed on my end. All right, your pen for the night is going to be BC Bravo Charlie 09 for chapter 9, and we'll go with P for patient. BC 09P. There you go. All right, the last thing I want to say before everybody bounces out for the night. All of your assessments are in Canvas. They're there for you to download. If you go into the files section where your class schedule is, it shows you, what nights we're having class and what we're covering. If you go there, you'll find an assessments folder. Click on that, and it's got all of your assessments. The good news is Most of those you don't actually have to get tested on. All of your individual skills like long bone stabilization, joint immobilization, oxygen administration, when you see those, learn them. That's the skills you're going to learn in boot camp. But nobody's going to be sitting there with one going, all right, you missed a step. The ones you really need to master are going to be your actual assessments, your trauma assessment, patient assessment, and cardiac arrest. I'm sorry, trauma, medical, and cardiac arrest. All right, so those are the big ones. And what's going to happen is when you go to do your actual evals, you're going to do one of those assessments. And those individual skill checklists, you're going to have to do those interventions somewhere in that assessment. So they're not going to switch over and hold that assessment sheet. They're just going to expect you to do the intervention through the trauma assessment or through the medical assessment. And that's it. All right, so your actual evals are going to go pretty quick, a lot faster than they used to. Used to be we had a station for oxygen administration, we had a station for the BVM and a station for the OPA, and it took all day. It was horrible. It was horrible on the assessment, on the assessors as well. A lot more streamlined. So go ahead now, get the trauma assessment and the medical assessment, and start memorizing them. All right. I don't want you to show up to boot camp and not know what's on those sheets. It would tickle me pink if nobody needed their sheets for boot camp. But if you do, if you just haven't quite got it memorized, that's okay. But anyway, I'm not going to keep you all any later. It's already after 9 o'clock. The next class is a week from tomorrow. You're going into your week off. So Thursday, Saturday, Monday, Wednesday, but it starts next Thursday, not tomorrow. All right. If there's no questions, I'm going to go ahead and kill the recording and get this uploaded. Y'all have a great night. If you need anything, hit me up or catch me in the Facebook group, whatever. And we'll work on it. And I'll see y'all in a week. Have a good night.